Okay, sorry, the mic was on mute. Am I audible now? I'm sorry, the mic was on mute. Uh, is it audible now? Yeah. A very good morning, everyone. I think it should be audible and I should be visible right now. All okay? I'm just waiting for everybody to just give me a thumbs up. Okay, sorry, the mic was on mute. Oh, thank you, Dr. Gurdeep Saini. Thank you so much. Okay, beta, let us now start. I have a list of all the doubts that you wanted to ask, and I have prepared everything. And this will be around 2+ hours. It will be 2 to 3 hours, anything around that. And take it easy. Take a pen and paper. All the students who have the One Touch PSM booklet, this video you can watch it anytime, maybe later also in 2x speed. But before watching this video, all those who have One Touch, you should be revising the One Touch PSM. I am very proud of my One Touch PSM book. I don't know, it's actually, I would say, a very loving book, because one page for every chapter, like that's the crux of the page. So even I am astonished, I am surprised, and I am very proud of the One Touch PSM, and I thank God that I was able to do that project. And it will definitely be helping you during this time. This is the time for One Touch PSM revision, when you're just 7 to 8 days before the exam. Anyways, let me just start the session, beta. I would like to start the session with prayers to God that everybody of you, all those who are watching this video, all those who are not watching this video, everybody should get the marks that you actually want, and you should be able to clear this NEET exam and get the seat, dream seat of your choice. And that dream should not be a dream anymore, it should become a reality. But in the past 5 years of NEET examination, maximum questions, maximum MCQs have been coming from epidemiology. You can see 13 questions. There's a summary of the last 5 years. Last 5 years mein kaisa gaya NEET. You can just have a look. Planning and environment is another big topic. Then we had biostats and vaccines, communicable disease, non-communicable disease is another story. But you can see that major chunk is only from 4 or 5 chapters, that is epidemiology, health planning, environment, biostats, and vaccines. So I would like to just give you a heads up on this, that this year the exam will not be any more different. It has to the key areas as far as I expect. See, future to kisi ne nahi dekha na, nobody has seen the future. But we should not be anxious about the future also. What we are supposed to do, karm kiye chal, फल की चिंता ना कर. That is what you are supposed to do right now. You have to work hard. People might be saying that you should clear the exam, you should do this. Exam के बाद भी ना, the first thing that your parents will ask you, पहली चीज parents क्या पूछेंगे, और भी exam कैसा गया. In fact, many teachers are also going to ask you, और भी exam कैसा गया. And सिर झुका के बोल के जाते हैं, यार अच्छा गया, ठीक गया, बहुत अच्छा गया, हो गया, देखेंगे रिजल्ट. We don't have any answers for that, right? So please make sure that every जो ये noises हैं, people who are saying everything, let them keep on saying everything. You are supposed to work, and this is what you need to work right now. You have to keep your focus very hard, and इसी focus पे ही चलते रहना है. Maximum questions beta इस साल, what we are predicting is what I am predicting. Nobody knows about the future, I'll say again, but what I am predicting is epidemiology. Then we might have good amount of questions from environment, may be kind of important role play, especially the air and the water, entomology, environment. And then we have a lot of questions always from national health programs and the healthcare system of India, or health planning. So epidemiology always will have to take the center stage. Next in line, I would like to say that MCH every year has been asked so many times in the exam. So this year maybe MCH will be there, but according to me, I feel MCH would be slightly on a slower pace. MCH में से आएंगे क्वेश्चंस, बट इट विल बी स्लाइटली ऑन अ स्लोअर पेस. बट yes, healthcare systems, immunization is another high risk area. So these are like majority of the questions. Make sure that you study these topics and go. So beta, I have taken all your topics, I have taken all your doubts, and let me just quickly cruise through the story. These are a few students who are regularly motivating me to make this session, but I'm always scared to do a session. It's inside me. I am scared to do a session just very few days before the exam. मुझे डर लगता है कि यार कोई आपका टाइम ना वेस्ट कर दूं मैं. So I pray to God that God should give me strength to save your time. Anyways, let's take on the first MCQ. Which of the following is not a feature of cohort studies, bache? What do you want to say, beta? Which of the following is not a feature of the cohort studies? Shows natural course, not a feature है. मैंने questions, ये all the MCQs I have prepared are fresh prepared MCQs. These are just for this session, and this session will be only hanging around online, live, free of cost for everyone till the NEET exam. Which of the following is not a feature? बताओ जी. Please shoot your answers. What do you think? Which of the following is not a feature? Uh, क्या बोलते हो? Which of the following is not a feature for cohort studies? Shows natural course of disease, finds incidence, finds risk ratio, goes from effect to cause. What do you think? Goes from effect to cause. Yes, absolutely correct. It goes from cause to effect. Absolutely correct. Very nice. Very quickly, which of the following is not a feature of cohort studies? Beta, it shows natural course of disease. This is correct. This is true. It helps you find incidence. This is true. It finds risk ratio. This is also true. It goes from effect to cause. This is the best answer you need to mark over here. A few questions. This just take a screenshot of this lecture. Take a screenshot, and this is a rough summary of epidemiology for you. What are cross-section studies, beta? What are cross-section studies? Cross-section studies, a very quick review, is the snapshot of the population. Cross-section study is a snapshot of the population where you take a general population, listen to every word that I'm saying right now. You take the whole population, and in the total population, you find out how many people have disease and how many people do not have disease. So what do you find out? You find out the prevalence. What do you find out? You find out the prevalence. There are chances of a bias called as selection bias. Coming over to the next one, that is case control study. In case control study, we take people with disease and non-disease. You start with people with disease, non-disease, and you find odds ratio. Beta, what do you mean by odds ratio? Odds ratio is given by the formula. Odds ratio is given by the formula A into D over B into C, where A, B, C, D are the cells in the 2 by 2 table. Odds ratio is also called as a cross product ratio. Odds ratio is also called as a cross product ratio. Very important, frequently asked MCQ. What is the typical bias in a case control study? It is recall bias. Many times examiners have asked you, last year also I think in INSET and the NEET exam, there was a question on the leukemia ALL from hospitals. So you take cases of ALL from the hospital. Where will you take the controls from? Please note that the cases and controls, they are dependent on whether you have the disease or not disease, but they all should have the they should be from the same population. They should not be from a different population. Case control has been a lot of times asked in your exam. Multiple risk factors can be assessed. This is a prospective MCQ. I think this question can come this time. Multiple risk factors can be assessed in the same disease. So one disease is there, COVID cases, and then you find out the risk factors. That is what is a case control study. It is usually for rare disease. I'm not saying case controls are for rare disease. For rare disease, we do a case control study. It is the study of choice for rare diseases. It goes from effect towards the cause. It is less time taking and less expensive. Coming over to the next one. What is a cohort study? Beta, cohort studies, these are follow-up studies. These are prospective studies. Cohort studies are follow-up studies, prospective studies. The unit of choice is, the unit of study is an individual. Risk factors are exposed and non-exposed. It is the uses, it finds out a risk ratio. What do you mean by a risk ratio? Risk ratio is given by the formula incidence exposed divided by incidence non-exposed. Incidence exposed divided by incidence non-exposed is known as risk ratio. So there are special biases that is called as Hawthorne effect or attrition bias. What is Hawthorne effect? It is change in behavior. Mark the word, it is change in behavior while under observation. What do you mean by attrition? Attrition means loss to follow up. Attrition means loss to follow up. Multiple outcomes can be assessed. This is again a prospective MCQ. I think this question can come in your exam. It is for rare risk factors, cost to effect, and more expensive and more time. This is a very important table for you. It is summary of the total epidemiology that you are supposed to know for the exam. Let's go to the next MCQ. The incorrect matches. Selection bias for case control study, Hawthorne bias for cohort studies, Bergsonian bias for hospital based, and publication bias is there in cross section study. The incorrect match is, what do you think is the incorrect match? Selection bias, can you get in a case control study? In a case control study, can we get a selection bias? Yes, we can get. Hawthorne bias is there in a cohort study. Yes, it is possible. Because in cohort studies, these are follow-up studies, and there could be chances of change in behavior while under observation. Bergsonian bias, there is a technical definition of Bergsonian bias, beta. Hospital based case control study. याद रखो Bergsonian. Berg is like you can remember Berg as a hospital. So Bergsonian, बकवास काम है ये. Bergsonian hospital case control study. पब्लिकेशन बायस बेटा क्रॉस सेक्शन स्टडीज में पब्लिकेशन बायस हो सकता है, बट यूजुअली लाइक different cross section studies can have publication bias, but publication bias is usually in evidence based medicine. Evidence-based medicine may we can find publication bias where some of the researches have been published, other researches have not been published. Another MCQ on publication bias is what is the plot that we make to find out the publication bias. The plot that we make to find out the publication bias is called as a funnel plot. What is a funnel plot? Funnel plot is to find out the publication bias. Funnel plot ऐसा होता है, you see, ideally you should have all studies equally spaced on the left side and on the right side. So equal होना चाहिए. Some studies are negative, some studies are positive. अगर कभी publication bias happens like this, like more studies are there on one side, this phenomena denotes a publication bias, that only some of the particular researches are being published in the journals. Why not the other researches? That is evidence of, that is like a proof for publication bias. It is found in evidence-based studies, studies which could be case control, cohort, and so on. Let's move to the next point. Please remember that hospital-based case control studies, differential hospital rates. What is this? What is the bias over here? This is called as a Bergsonian bias. Bergsonian bias. What do you mean by incidence prevalence bias? Beta, it is a Neyman bias. Neyman bias is an incidence prevalence bias. What is loss to follow up? Loss to follow up is people leave the study and they just go off. This is called as attrition. Attrition bias is loss to follow up. Change in attitude while under observation is what we have already talked. Hawthorne effects. Blunting of response by demotivated researcher or demotivated observer. Remember, demotivated observer, this is called as a golem bias. What is a golem bias? Golem bias is a bias where there is lesser response because बंदे का दिल ही नहीं था काम करने का. That is what is a demotivated researcher. And misclassification bias can happen anywhere, but it is typically found in case control studies. It is typically found in cohort studies. In both of the studies, we may find misclassification where you are not able to classify people accordingly, right? So that's all for regarding the bias. Yes, one point more. How do you treat bias? Very important point. This is a prospective MCQ. How do you treat bias, beta? Bias is treated by blinding. That is the best answer. Or we can also use randomization. Randomization. What is randomization? It is a known and equal chance. Randomization is a known and equal chance of selection. Next is how do you treat known confounders? Beta, known confounders can be treated by matching. We can also treat them by randomization. But the best answer over here should be matching. Next is unknown confounders. Unknown confounders are treated by RSSR. RSSR, randomization, standardization, stratification, and regression. Out of these, which of the following are the best methods? The best method is randomization. Of course, the most statistical method, the statistical approach is regression analysis, but randomization is a universal treatment. Randomization can treat bias, randomization can treat known confounders, and randomization can treat unknown confounders. Randomization is a universal treatment. Coming over to the next MCQ. Death rates of two population with different age groups needs to be compared. Death rates of two populations with different age group needs to be compared. The reference population is available. Very important point, the reference population is available, but the age specific death rate are not available. The best method to compare the death rates will be, what do you want to say? Direct standardization, indirect standardization, linear regression, or logistic regression. What do you want to say? What do you want to say? The death rates in two populations with different age groups needs to be compared. The reference population is available, but the age specific is not available. So what is your best answer? What do you want to say? Direct standardization, indirect standardization, linear regression, or logistic regression? Beta, in this MCQ, very frequently they will ask you questions on this. What do you mean by standardization? Anybody who would like to try over here? What do you mean by standardization? What is standardization? Anybody who would like to answer over here? What do you mean by standardization? Any idea over here? What is standardization, beta? Standardization, please note, is used to compare death rates. It is used to compare death rates. It is used to compare death rates. Now the death rates, it can be a direct standardization or we can have indirect standardization. Okay, so when do we do a direct standardization? Standardization. आपका आंसर गलत हो गया. It is not option C, linear regression. What do you mean by standardization? Standardization can be a direct standardization, indirect standardization. In any case of standardization, we should have a reference population. So reference population is always required. It is always required. So it is very simple to understand. It is always required to have a reference population. What do you do in case of direct? In case of age specific death rates. What is ASDR? Age specific death rates. If the age specific death rates of the standard population is available and of the comparing population is also available. ICO stands for in case of, okay? So all those who have attended my classes, they must be knowing it, in case of. So in case of age specific death rates are available, then you can do the direct standardization. However, in case of ASDR is not available, if the age specific death rates are not available, in those cases, we have to do indirect standardization. The point is, reference population is always required. So how would you do indirect standardization? Indirect standardization is the observed deaths divided by the expected deaths multiplied by 100. This is called as a standardized mortality ratio. It is called as a standardized mortality ratio. It is called as standardized mortality ratio, SMR. What is the formula for SMR? Observed deaths divided by expected deaths into 100. That is what is indirect standardization. So a direct question over here, death rates of two populations were supposed to be compared. The reference population is available, but the ASDR is not known. What is the population? What is the standardization you're going to do? But please note, it is indirect standardization. Which of the following kits are available at a PHC? Which of the following kits are available at PHC? What do you mean by PHC? PHC stands for a primary health center. PHC stands for Primary Health Center. PHC stands for Primary Health Care Center. Which of the following kits are available? Kit A, D, E, G. So what do you want to say? Beta, there are so many kits for all the health centers. So there are so many kits, like it goes from kit A till kit P. You do not need to bang your head to remember kit A, B, C, D, E, F, G, H till P. You will go mad. Nobody remembers that. There's a list of the kits, so you just note how many kits are there. MCQ number 1. How many kits are there? Kit number. There is kit number A till kit number P. Next MCQ. Question number 2. Which kits are available at a sub-health center? At a sub-health center, we have kit number A, kit B, and kit C. So which are available at the sub-health center? Kit A, B, and C. Which of the following is available at a PHC? At a PHC, we have kit number D. At a CHC, we have kit E till P. We have kit E till P. So please note kit number E till kit number P. They all are available in a CHC. So that's what you have to remember. In a CHC, we have kit number E to P. PHC is kit D. Remember, कैसे याद रखोगे? PHC पे कौन बैठता है? Who's sitting at a PHC? At a PHC, it's the doctor who's sitting. So D for doctor, D for PHC. D for doctor in a PHC. D for kit D. So kit D is available at a PHC. ABC is available at a sub-health center. And CHC has E to P. So which of the following kit is available at a PHC? I think everybody has given the right answer. It is kit number D is available at a PHC. Next is Usha worker, urban Ashas, or the Usha worker will be assigned for how many houses? 300 houses, 1000 houses, 2500 houses, or 100 population. So what do you want to say? What do you want to say? Urban Asha workers will be assigned for how many population? Urban Asha workers will be assigned for how many population? Beta, this question is from NHM or the NRHM. You already know that there are two branches that we need to discuss. We need to discuss about the NRHM and the NUHM. These are the two components of the National Health Mission. NRHM was started in April 2005, whereas the NUHM was started in May 2011, and they both were merged together. So we have a couple of answers coming out as 2500 houses, 2500 houses. Anyways, let's see what is happening over here. So beta, under the NHM and the NUHM, so under the NRHM, I'm first discussing the National Rural Health Mission. Everybody should remember one CHC. What is CHC? Community Health Center. One CHC is for how many population? It is for 80,000 to 1,20,000 population. It is for roughly 100 villages. What will you remember? CHC is for how many villages? It is for 100 villages. Then we have as PHC. What is PHC? PHC is for Primary Healthcare Center. It is for 25 to 30,000 population, and for how many villages? It is for 30 to 40 villages. It is for how many villages? 30 to 40 villages. Then we have is the Sub-Health Center. Please remember that the Sub-Health Center is for 5 to 6 villages. The Sub-Health Center is for 5 to 6 villages, 3,000 in hilly areas to 5,000 in plain areas population. Then we have is the Asha worker. Asha worker is for every 1,000 population. Please note, it is my request with folded hands that the current norm for Asha worker in the area is still 1 per 1,000. Yes, there are some reports where we want to achieve 2 Ashas, but for your MCQ exam, it is my request with folded hands. Please let Asha live in peace. You also live in peace, and let me also live in peace. Please remember, one Asha is for 1,000 population. Current norm is that 1 Asha for 1,000. The current value is 1 Asha is roughly for around 800 for 980 population. That's in general. So current value, the current status of the Asha worker is this much. We want to achieve 1 Asha for every 1,000 population. Yes, the proposal is to achieve 2 Ashas for every 1,000 population, but that's just a proposal and it has not yet been implemented. The implemented is only this one. So coming back to the story, please note this is case of National Rural Health Mission. Coming over to the National Urban Health Mission, in Urban Health Mission, you know that there is a CHC. What is CHC? Urban CHC. Urban CHC is for 2.5 lakh population in all cities and 5 lakh population in metros. Urban PHC is for 50,000 population. One A&M center is for every 10,000 population. You should also note that the urban CHC, urban areas, the number of beds in the urban areas should be 50 beds in all CHC, and it should be up till 100 beds in the FRU CHC. FRU CHC, the number of beds should be 50 in normal urban CHCs. Normal urban CHCs, you should have 50 beds. In FRU CHC, we should have 100 beds. The PHC norm is still the same. It is 4 to 10 beds depending on whether it is a high load PHC or a low load PHC. A&M centers, and then we have is the community health workers. These are the urban ASHAs. The urban ASHAs or the USHA workers, they are for how much population? Please note, they are for 1000 till 2500 population. So 1000 till 2500 population. I'll write it on the other side. They are for 1000 till 2500 population. Now this taking a family size of 5 beta. How many houses will be there? 1000 people living, 5 people in one house. So 1000 people will be how many houses? Roughly around 200 houses to 500 houses. So 200 to 500 houses is assigned for the USHA worker. Coming back to your MCQ now. Urban ASHAs will be assigned how many houses? They are assigned 200 to 500 houses, or you can say 1000 till 2500 population. So what is your best answer? Option number A. Option number A. Absolutely correct. Gurdeep Sen, it's 25 people and not houses, 300 houses. You see, that's how the tricky MCQs are. So it is not for 1000 houses. It is for 1000 population. It is for 2500 population, not for 100 answers, 100 population. So the best answer over here is it is for 300 houses. So regarding beds, many questions had been coming on the Telegram group. So all the students who had asked me regarding the number of beds, beta, in a sub-health center, in a sub-health center, a sub-health center or a sub-center, we can have 0 to 3 beds. You already know that the sub-center could be type A, could be type B. What is type A? Where there is no birth facility available. What is type B sub-center? Where there is birth facility available. So birth facility 2 to 3 beds, no birth facility 0 to 1 bed should be there. Next in line is in the PHC. In PHC, we can have PHC type A or type B. What is PHC type A? Where there are less than 20 deliveries a month. Less than 20 deliveries a month, that is called as a low load PHC, and type B is more than 20 deliveries per month. So if the high load PHC is there, you need more number of beds. It is roughly around 8 to 10 beds should be there in high load PHC. In low load PHC, it is 4 to 6 beds should be available. Coming over to the CHC, lot of questions have already come. CHC, community health center, can be there in rural areas, that is a CHC, or we can have in urban areas, that we call as a UCHC. Now each one of them can be FRU. So we can have a CHC non-FRU, or we can have a FRU CHC. I hope you're getting it. Urban healthcare center, we can have a non-FRU. We can have a non-FRU CHC, or we can have a FRU UCHC. We can have a FRU UCHC. I hope this classification is clear. Right? So in very simple now, if you have understood this, in this area, in the CHC non-FRU, we get 30 beds. FRU CHC should be 50 beds. 50 beds. Non-FRU urban healthcare center should be 50 beds. FRU urban health center should be 100 beds. Right? And very important, you should also note FRU CHCs or the health and wellness centers, they all are with 100 beds. They all are with 100 beds. If you get single best answer in cities, in metropolitan cities, or in cases where the CHC has been upgraded to the health and wellness center, it is 50 to 100 beds only. Single best answer, you should mark 100 beds. District hospital are always more than 100 beds. District hospital is always more than 100 beds. Coming over to the next, this one is super important. It is a 7-star MCQ table for you. This table has been asked millions of times in your exam. How many nurses do we need? Prospective MCQ beta. How many nurses do we need? We need one nurse for every 5,000 population. Health workers should be 5,000 or 3,000 in hilly areas and 5,000 in plain areas. There's an old Ghisawa MCQ. Nobody will ask you again. Trained dai should be there in village. Nobody will ask you. Health assistant, again a prospective MCQ. It should be one health assistant available at every PHC. Prospective MCQ question for you now. Pharmacist, again MCQ for you. It is 1 per 10,000 population. Lab technician, question for you, 1 per 10,000 population. Asha Ghisawa MCQ, nobody will ask you. It is 1 Asha for every 1,000 population. I hope this table is a summary table. It is the suggested norms for the health professionals, and it is very important table for you. Question coming over to the levels of prevention. Yesterday in the Telegram group, so many students were asking this question again and again, what are the levels of prevention? So providing cast for fracture wrist is level of what level? Is level of prevention dash level of prevention. What do you want to say? What level of prevention? Providing cast for fracture wrist is what level of prevention? Primary, secondary, tertiary, or any of the above? What do you want to say? Providing cast for fracture wrist is what level of prevention? So, any idea, any doubts, anything you would like to say? Not doubts, like any answer you would like to put forward? Providing cast for fracture wrist is dash level of prevention. Please note that the fracture wrist, what is it? Is it a risk factor? Is it a disease? Is it a complication, or is it disability? What do you want to say? So some are saying secondary, some are saying tertiary. What do you want to say? What is fracture, beta? My question is, what is fracture? What is fracture? Is it a disease? Is it a risk factor? Is it a complication? Is it a disability? Many are saying tertiary level. So Gurdeep Saini says B. Deepak Sarkar says B. Very nice. Sangeeta says C. So good. Many of you are giving me different answers. What do you think? If you all are saying, bache, that it is option number C, if you are saying, I am not saying till now, if you guys are saying that it is tertiary prevention, if it is a tertiary prevention, that means you want to say it is complication. That means fracture is a complication. So what is the disease? A person fell off from the roof. That means that was a disease. Falling is a disease. Falling is a disease, or getting a fracture is a disease here. Common sense. Common sense. Overthinking syndrome in students. Do not overthink. What is fracture here? Fracture is a disease. Fracture is a disease. If there is fracture and later on you do not take the cast, or patient was not put on plaster, the patient may develop a non-union, the patient may develop a malunion, the patient may go into compartment, whatever. Complications can happen from a fracture. Fracture is a disease. Fracture is a disease. What level of prevention? What level of prevention? It is secondary level of prevention. Treating fractures is a secondary level of prevention. Fracture is a disease which is taken care by the orthopedics department. It is a disease, absolutely correct. So you all must be knowing this table. This is my Takia Kalam table. This is my favorite table. This will solve all your doubts on levels of prevention. All your doubts on levels of prevention, all your doubts on level of prevention can be solved by this table, simple table. You already know that there is a risk factor. Risk factor may cause disease. Disease may cause complication. Complications may cause disabilities or death. If you prevent the risk factor, what is the level of prevention? It is primordial prevention. If you prevent a disease, what level of prevention? It is primary. If you prevent the complication, what level of prevention you're doing? Secondary. And if you preventing the disability, it is a tertiary. So now this patient already had the disease, that is the fracture. What level of prevention? You're preventing the complication by giving a proper cast or plaster or a treatment for the fracture. So what is the treatment for fracture is to give them cast. So what level of prevention? What makes you think it is tertiary? The answer is, correct answer is, it is a secondary level of prevention. Tertiary is wrong answers. Tertiary is bekar, wrong answer. It is not a tertiary level of prevention. If the MCQ was providing operative treatment or providing reconstructive cast to a fracture wrist with malunion, where you have scaphoid fracture and there was non-union malunion, and then you are doing a corrective surgery, or you are doing some prosthesis, or you are doing some what do you call kind of more tailor-made or custom-made cast for that scaphoid non-union fracture. In those cases you are treating the complications, so therefore that would be resulting in a tertiary level of prevention. But this is a simple MCQ. It is a secondary level of prevention. Which of the following vaccine should not be kept on the ice packs? Another MCQ for you. Another MCQ for you. Which of the following vaccine should not be kept on the ice pack? Should not be kept on the ice pack. What do you want to say? Which of the following vaccines should not be kept on the ice packs? BCG, rotavirus, hepatitis B, or Japanese encephalitis vaccine? What do you want to say? BCG, rotavirus, hepatitis B, or the JE vaccine? What do you think is the best answer over here? Which of the following should not be kept on the ice pack? So beta, if you just look at the national vaccine program, you know that so many vaccines are available and so many things are available, and there are some vaccines which are heat sensitive, there are some vaccines which are freeze sensitive. So please remember, you can remember this table, you can remember this chart, that which vaccines are always kept in the ice pack or over the ice pack. So placement of vaccines in the routine immunization session. So whenever we are opening any vial vaccine, there are some vaccines which you should be keeping over the ice pack. So please remember, Mera Rota Bichara Jija OPV. Remember, Mera Rota Bichara Jija OPV. These are the vaccines which are kept on the ice pack. जब जीजा रोएगा तो उस जीजे को चुप कराने के लिए what do? You give them ice pack. Mera Rota Bichara Jija. OPV is, of course, everybody knows it's a heat sensitive, so it should be there on the ice pack. But please remember, Mera Rota Bichara Jija. You can remember it as Mera Rota Bichara जीजा. So all those who understand Hindi, they must be understanding this. जीजा रोएगा तो क्या करना है, उसको क्या करना है, उसको चुप कराना है. So these should be placed on the ice pack. These are heat sensitive vaccines. These are heat sensitive vaccines. So coming back to the MCQ. Which of the following vaccines should not be kept on the ice pack? So BCG, yes, it should be kept on the ice pack. Rotavirus, yes, it should be kept. JE, yes, it should be kept. Please remember that hepatitis B, it is a freeze-dried vaccine. It is a freeze-dried vaccine, and it is a sorry. Hepatitis B is a recombinant. I'm sorry. It is not a freeze-dried vaccine. Hepatitis B is a recombinant vaccine, and it is a freeze-sensitive vaccine. It is a freeze-sensitive vaccine. Please remember that hepatitis B is a freeze-sensitive vaccine, and it is a recombinant vaccine. It's not a freeze-dried vaccine. It is a recombinant type of vaccine, freeze-sensitive vaccine. Which vaccines are freeze-sensitive? This can be again MCQ. Which vaccines are freeze-sensitive? Beta, freeze-sensitive vaccines are freeze-sensitive vaccines are hepatitis B more than DPT, pentavalent more than PCV, DPT, and TD. Hepatitis B more than pentavalent, more than PCV, DPT, and TD. Which vaccine is both heat and freeze sensitive? Which vaccine is both heat and freeze sensitive? What do you want to answer? It is single answer. IPV is both injectable inactivated polio vaccine, is both heat and freeze sensitive. Which is the freeze sensitive vaccine? That is hepatitis B more than pentavalent, more than PCV, DPT, and TD. So out of these vaccines, which vaccine should not be kept on the ice pack? Sir, freeze-dried vaccine कौन सी है exactly? There is confusion about yellow fever. Yes, yellow fever is a freeze-dried vaccine. Any vaccine in which you need diluents, beta. I'll just put a table over here. Which are the freeze-dried vaccine? Freeze-dried vaccine means the powder form vaccine. The powder form vaccine used under the National Immunization Schedule. Many powder form vaccines are there. We can have measles. We also have measles and rubella. We also have is the Japanese encephalitis vaccine, measles, rubella. We also have is the BCG vaccine, yellow fever vaccine. They all are the freeze-dried vaccine. Most of the live vaccines, they are mostly the freeze-dried vaccine. They are powder form. So how do you reconstitute BCG? BCG is reconstituted in normal saline. BCG is reconstituted in normal saline. Measles, rubella, how do you reconstitute? Say with me. Please note, this is a 5-star MCQ topic frequently asked in your exam. What I'll do is I'll finish everything about immunization in just 5 minutes for you. So measles, rubella, remember M for measles, W for water. So in measles, rubella and measles vaccine, how do you dilute? What is the reconstituting material? It is water. Which water we use is distilled water. Distilled water. Distilled water is used for measles, rubella, Japanese encephalitis. What is the reconstituting agent? It is phosphate buffer. Phosphate buffer. It is phosphate buffer. Yellow fever is with a special diluent which is available with the yellow fever vaccine. There's no name to it. It is a special diluent which is available with the yellow fever vaccine, and these are the freeze-dried vaccine. So very quickly, I would like to ask you another MCQ. One more MCQ. We're still on immunization. During a session, 6, 10, 14 weeks and 9 months, when more than one vaccine is to be administered on the same day, is there a definite sequence in which the vaccine needs to be given? So when more than one vaccine is to be administered on the same day, is there a definite sequence in which the vaccine needs to be given? Yes, there is a definite sequence. Please note, whenever the patient will come to us, the first thing that we have to give to the child is the oral vaccine. The first thing that we give is the oral vaccine. Whenever guest enters into your house, what do you start with? Do you directly give them food or you give them water first? उनको चाय, पानी, दूध या जो भी पूछना चाहते हो, you ask that thing, right? So the first thing that we asked is fluid vaccines which are given orally. Next in line we have all the injectable vaccine. Please note that the last vaccine will always be the penta vaccine. The last vaccine is always the penta vaccine. Why do you think penta is always the last vaccine? Why do you think pentavalent is always the last vaccine? Beta, pentavalent is the last vaccine. Pentavalent is the last vaccine to be given. Why do you think pentavalent is the last vaccine? Because pentavalent causes unconsolable cry, and because of unconsolable cry, when the baby is going out, at that time we ensure that the pentavalent is given, because if you give the pentavalent first, then the child and you will be the biggest enemy on this planet, right? So we don't want to mess around with children. Children are so cute people, so we respect children. First thing is we give them oral vaccines, we give them something to drink, and child happy, mother happy, and then slowly you show your bad faces, and the last face that you show yourself is with pentavalent vaccine. Now the child is going to make hue and cry. What are the side effects of pentavalent vaccine? Side effect of pentavalent vaccine is unconsolable cry with the neurological deficits. There could be unconsolable cry with neurological deficits. Absolutely correct. There is painful vaccine. Next, I would also like you to remember this flashcard. I have already put all my flashcards, beta. All flashcards are available in my One Touch PSM. So One Touch PSM, it is a collection of all the flashcards. All flashcards are also available on my Instagram channel. So Instagram is like full sequence of all the flashcards. It's also available more or less in the Telegram group also. But Telegram group is mostly for all the doubts, all the questions, all my audio notes and audio explanations. Coming back to this flashcard, beta, how many diseases are there under this program? This could be your prospective MCQ. Question: how many diseases are there under this program? Total we have 12 diseases. So two are subnationally. In fact, it is not two, it is now one subnationally, because PCV is now given to every child in the country. So we have 11 diseases, 11 programs, 11 diseases which are under national level, and one vaccine which is under subnational. Upper age limit, this is a 10-star MCQ topic. Very frequently you get a question: unimmunized child. So beta, please note that if the child is unimmunized, what are the vaccines you're going to give? OPV to be given till 5 years, DPT till 7 years, MCV till 5 years, JE till 15 years, and BCG pentavalent IPV till 1 year of age. So it is a 10-star MCQ for you. Please remember, these are very frequently asked MCQs. These are very, very frequently asked MCQs. On follow-ups, complete the schedule of OPV and DPT by ensuring complete interval between two vaccines, and the parents are advised to be compliant to the NIS vaccine. Anyways, you can just leave this point. Next is a small update for us. Under the new program on January 1st, 1st of January 2023, we started with the third dose FIPV. We started with the third dose FIPV. When do we give the third dose FIPV? It is started to be given at 9 months of age. What is the route of this third dose IPV? The route of this third dose IPV, the route is, it is given in the left upper arm. Please note, it is given in the left upper arm, third dose. The first and the second doses, these are given in the right upper arm, whereas the third dose is given in the left upper arm. So please remember, this is just a small update, and this is again a very important 7-star MCQ table for you. It's again from a flashcard list, and this is the site where we give vaccines. Oral vaccines, where do we give, or when do we give oral vaccines? Rotavirus and OPV, these are given at 6, 10 and 14 weeks. So OPV, the dose is 2 drops, rotavirus is 5 drops. They are oral vaccines. Then in the left upper arm, we are going to give BCG, Japanese encephalitis subcutaneous vaccines, and FIPV third dose. Please note, it is only the third dose. Next is anterolateral thigh. Anterolateral thigh, we are giving pentavalent vaccine and hepatitis B. In the anterolateral thigh, right side, only one vaccine, that is pneumococcal vaccine, and in the right upper arm, we have 2 vaccines, measles, rubella, and FIPV. You can remember it that in the child left arm and right arm, we have one subcutaneous, one intradermal, one subcutaneous, one intradermal. Which is the intradermal on right upper arm? It is the FIPV. Which is the intradermal on the left upper arm? It is the BCG. So now we have the FIPV also. So these are very frequently asked MCQs for your exam. Next is in the ILR. How will you place the vaccines in the ILR? The vaccines have a particular sequence to be placed in the ILR. The vaccines have a particular sequence to be placed in the ILR. You can remember this by mnemonic that don't hurt people in this room because Japanese manners outshine. So you can remember this by mnemonic, don't hurt people in this room because Japanese manners outshine. So D stands for the diluents. H stands for hepatitis B. People, P stands for pentavalent, and it also stands for the pneumococcal conjugate vaccine. IN stands for inactivated polio vaccine. This stands for the TD vaccine or the TT vaccine. R stands for the rotavirus vaccine. B stands for the BCG. J is Japanese, manners is measles and measles rubella, outshine is OPV. So that's the way we place in ILR. Placement of vaccines in ILR. Placement of vaccines in ILR. Placement of vaccines in the ILR. So at the first level, we have diluents, hepatitis B, pentavalent, PCV, IPV, TD, rotavirus, BCG, JE, measles, rubella, and OPV. So which vaccines are kept in the top? In the top shelf, we have the hepatitis B, and in the bottom shelf, we have is the OPV. Please note that this is the correct placement of the vaccines in the ILR. Okay. So there's another mnemonic. Many students asked me on the Telegram group yesterday, like what are the any mnemonic that we have for live vaccines. Beta, for live vaccines, you can. I have made this mnemonic, and it's easy for me to remember. Boy loves crime type cereals, right? So crime cereals or crime type cereals, boys would love that. Boy stands for BCG. Loves is like live vaccines, okay? Loves is the live vaccines. C stands for chickenpox. R stands for rubella. I stands for influenza vaccine. M stands for measles and measles rubella vaccine. E stands for Japanese encephalitis vaccine. Type stands for oral typhi 21A. Oral typhi 21A. Oral typhi 21A. So these are, like, you can remember these all as the live vaccines. Of course, we also have other live vaccine, which is the yellow fever vaccine. For yellow fever vaccine, I would like to tell you, yellow fever vaccine, when does the effect will start? The effect will start from 10 days. It is till lifetime. The effect will start from 10 days till lifetime, and once you reconstitute yellow fever vaccine, it should be used within 30 minutes. Within 30 minutes of reconstitution, we should be using the yellow fever vaccine. So yellow fever is one disease which is exotic in India. Yellow fever vaccine is contraindicated to egg allergy patients. Egg allergy cases, yellow fever vaccine is contraindicated. Please note that pregnancy is a contraindication, but in case of pregnant, listen to it carefully, pregnancy may, we should not give yellow fever vaccine. But if a pregnant female comes and she says that she's traveling to Mexico, or she's traveling to Brazil, or she's traveling to Africa, in those cases pregnancy is not a contraindication, because yellow fever disease is exotic in India. So one is, we say to the mother that, madam, please don't travel because yellow fever is there. Now, in case she says, no, I am going to travel, in those cases, we have to give the yellow fever vaccine. Pregnancy is not a contraindication for yellow fever vaccine. Contraindication is only one, that is egg allergy to the patient. Severe egg allergy, it should be used within 30 minutes of reconstitution, and it is effect is from 10 days after the vaccine till lifetime. Next is, you can see over here, which is in red color. These are the JIPI vaccine, JIPI. These are the JIPI vaccine. JIPI vaccine are the killed vaccine. Japanese encephalitis, we have the live vaccine and the killed vaccine. IPV, that is inactivated injectable polio vaccine, pertussis, and influenza. Influenza, you already have studied influenza. We can have the live vaccines also. Influenza, we can have the killed vaccines also. So these are some of the important MCQs from vaccines. Okay, so which of the following vaccine, coming to the next MCQ, which of the following is correct regarding the targets of the national health programs? Coming over, switching now to the national health programs topic. Which of the following is correct regarding the targets of the national health programs? So this is again a prospective MCQ, I would say, prospective MCQ. Zero AFP cases from the district. Malarial parasite rate or index is less than 10%, under 5 mortality rate of less than 25 per 1000 live births, total fertility rate of less than 1. Which of the following is correct regarding the targets of the national health program? So what do you want to say? Which of the following is correct regarding the targets of the program? So if you just look at this summary table over here, anybody who would like to answer, like which of the following is the correct target? Which of the following is correct target? What do you want to say? Anybody who would like to say anything? Option B. Option B is correct. Okay. Only one student. This is a very Gisawa, like not Gisawa, it's a very important question. So I don't know why you guys are not answering this. What is the most important target of the national health program? Which of the following is correct regarding the target of the national health program? Option B, option C, C. Beta, if you look at all the targets, there's a summary table for you. If you look at all the targets, I have prepared a summary table for you. Can you see this? This is a summary table for you. Take a screenshot of this. All the 9 national health programs, 11 national health programs, I have summarized in single screen. All the national health programs, all the targets I have summarized for you in a single screen. Beta, targets for the NTEP, National TB Elimination Program. Targets for the National TB Elimination Program: deaths to be reduced more than 90%, incidence to be reduced more than 80% by year 2025. NACO program, the target is to achieve the 90-90-90 strategy. What is 90-90-90? 90% of all HIV should be diagnosed, 90% should be treated, and 90% should have viral load decrease, and there is zero incidence by 2030. National Vector-Borne Disease Control Program. Please remember that the API, what is API? API stands for Annual Parasite Incidence. API stands for Annual Parasite Incidence. This is an important question. It is not Annual Parasite Index. API should be less than 1 per 1000. The ABER, Annual Blood Examination Rate, should be more than 10%. Okay. So it should be more than 10%. Coming over to the maternal mortality rates or the ratios, mother and child health indicators. Please remember, under 5 mortality rate to be less than 25 per 1000 live births, neonatal less than 12, and maternal mortality ratios to be less than 70 per lakh live births. These are prospective MCQs, again questions which can be asked from this topic. Family planning program, the couple protection rate should be more than 60%, total fertility rate less than 2.1, NRR equal to 1. NRR equal to 1. Coming over to NLEP, National Leprosy Eradication Program, beta. Leprosy eradication, the prevalence should be less than 1 per 10,000. ANCDR, annual new case detection rate, should be less than 10 per lakh. NPSP, National Polio Surveillance Program, the AFP reporting rate, prospective MCQ bache, prospective MCQ, AFP reporting rate should be more than 1 case of AFP reported every lakh per lakh every year. Stool adequacy rate should be more than 80%. Vector-borne blindness program, it is 0.3. Now it has been revised to less than 0.25%, but you can remember anything. Poshan Abhiyan, please remember Poshan Abhiyan, undernutrition to decrease by 2%, anemia to decrease by 3% every year, goiter rate less than 5% under the NIDDCP, and vitamin A prophylaxis, the bite hot spot should be less than 0.5% in children in the community. These are your targets which you need to remember. Summary of all the targets in normally in classes I spend around 2 days. This is just one slide for you guys, so make sure that you study all the targets for your exam and go. These are super duper 10 by 10 star MCQ topic for your exam. Next in line, most common cause of visual impairment in age less than 49 years. Most common cause of visual impairment in age less than the game changer MCQ, the critical point or the climax point over here in this question is age less than 49, that is the young people. What do you think most common cause of visual impairment? Yes, you have taken it correctly. It is not most common cause of blindness, it is the cause of visual impairment. Blindness hota to kya answer hota? What was blindness? Blindness is cataract. But cataract is not the correct answer because they are talking about visual impairment and in young people. Please remember that there's a summary table for you. Age more than 50 or less than 50. Talking about blindness first. Talking about blindness. Blindness may most common cause is untreated cataract. Most common cause of blindness in age more than 50 is untreated cataract. But MCQ पूछा जा सकता है, most common cause of blindness in young people is not cataract, it is non-trachomatous corneal opacity. Non-trachomatous corneal opacity is very frequently asked, and I don't know why so many students mess it up every time, every year. Age less than 50 years, it is not cataract. Age less than 50 years is non-trachomatous corneal opacity. Am I clear? Next is age more than 50. Age more than 50, it is untreated cataract, common sense. So now age less than 50, it is not cataract, it is refractive errors. Visual impairment ke liye, it is refractive errors. Overall, if I just want to say overall, beta, overall, most common cause of blindness, it is cataract. Cataract is such a huge problem. Roughly 67% of all blindness is because of cataract. How much is 67? 2/3 of all blindness is cataract. It is cataract. Next in line, age less than 50 years, blindness could also be because of non-trachomatous corneal opacity. Corneal opacity. Now that is very less, around 7.5%. But that 7.5% is the second number. Can you see the difference between 67 and 75? 7.5. 67% and next is 7.5%. But for your MCQ exams, you have to note that the most common cause is cataract, but the second most common cause is non-trachomatous corneal opacity for blindness in age less than 50 years. For visual impairment, if you talk about visual impairment, old people, it is again same answer, cataract. In young people, it is refractive errors. Visual impairment, it is refractive errors. Coming to this question now, most common cause of visual impairment in age less than 49, it is, I think everybody should answer it correctly now, it is refractive errors. So many students mess up this question. You're not the only one who's going to mess up this question. Everybody in this country would mess up this question if this was asked in your exam. Most common cause of visual impairment in age less than 49 is refractive errors, and most common cause of blindness in age less than 49 is non-trachomatous corneal opacity. Am I clear on this? Let's go to the next one. Cardinal feature of leprosy. Leprosy is again a big source of headache for everyone. It is a big source of headache for everyone. Cardinal feature of leprosy is all except. Cardinal feature of leprosy is all of the following except. So what do you want to answer? So what do you want to answer? Cardinal feature of leprosy is all except. I think the charging is out. Just a moment, guys. I need to correct my charger. Yeah, so I'm back now. I think sometimes you forget connecting all the cables except the charger. And charger is one point आजकल के जो iMacs and all these new laptops, so they don't have the port also. So sometimes you have to arrange so many things. Anyways, let's get on. Cardinal feature of leprosy is all of the following except. All of the following except visible deformity of hands, hypopigmented patch with sensory deficit, nerve involvement with weakness in the limbs, AFB in skin slit smear examination. So, what do you think is the best answer over here? Cardinal feature for leprosy is all of the following except. क्या बोलना चाहते हो? So, no one nerve involvement in paucibacillary, two or more than in multibacillary. Yes, that is correct. So, Sangeeta Chaudhary says A, Ashma Khan says C. I'm back now, I think. So, cardinal feature of leprosy is all of the following except. Beta, in leprosy, please note that the hypopigmented patch, hypopigmented or the reddish lesions, these are the cardinal features. The cardinal features. Am I clear now? Is the audio okay now? Is the audio okay? Yeah, there was audio disconnection, but just let me know if the audio is okay now. I'm waiting for your answers. Any, just let me know if the audio is all okay. Okay. So hypopigmented, the three cardinal features of leprosy. This is a very important prospective MCQ beta. This came in NEET last year. It was there in FMG exam last year. It was there in UPSC exam, INI set exam, question on leprosy. Leprosy has been 10-star MCQ, so there is a chance that you can get a question from leprosy this year again. So point number one, question number one, what are the cardinal features? There are three cardinal features: hypopigmented patch, involvement of peripheral nerves with the thickening or with loss of sensation with weakness or paralysis, and third thing is demonstration of the M. leprae in the lesions. Next is paucibacillary or multibacillary. How do you differentiate between pauci and multi? The cardinal feature for pauci is 5 or less lesions and no AFB smear positive. Please note that the nerve involvement is kind of doubtful now, but the cardinal features of paucibacillary is 5 or less than 5 lesions with no AFB smear positive from the smears from the wounds. And multibacillary is with any nerve involvement, 6 or more lesions, any skin smear positive. Please note that the single dose rifampicin is given to all family members. It is given to social contacts. And what do you mean by social contact? Social contact is when the contact time is more than 20 hours per week. Contact time of more than 20 hours per week, that is single dose rifampicin. Single dose rifampicin is given in 20 hours per week. What is the treatment for leprosy that we give? The treatment for leprosy that we give is for paucibacillary beta. For paucibacillary, we are giving two drugs in India under NLEP beta. If you get the question under NLEP, we are giving two drugs for paucibacillary and three drugs for multibacillary. We are giving two drugs for paucibacillary and three drugs for multibacillary. This is what is the NLEP regime. Please note that I know that the WHO regime is paucibacillary is given for 6 months and multibacillary is given for 12 months. That is the WHO regime. But in India, what we are following, if nothing is mentioned, I would suggest you to mark NLEP regime. If nothing is mentioned, I would suggest you to mark NLEP regime. If nothing is mentioned, please mark NLEP regime. A very quick review about the paucibacillary leprosy treatment. We have a green blister and we have a blue blister. Please remember, B for baby, B for blue, B for baby, B for blue. Blue is for paucibacillary child. Please remember, blue is for paucibacillary child age 10 years to 14 years. Blue is for paucibacillary child, B for baby, B for blue. Green blister is for adults. Green blister is for adults. Next in line, talking about the multibacillary leprosy, we can have a red color blister or a pink color blister, and we can have a brown or a maroon color blister. Please remember, B for baby, B for brown. B for baby, B for brown. Brown is for baby, baby is for blue, blue is for pauci, brown is for multi. B for baby, B for brown. B for baby. Baby means what? Baby means a child. Child is 10 years to 14 years. ऐसे याद रखो, 10 years to 14 years is child. Child is a baby. B for baby, B for brown, B for blue. Blue is for paucibacillary, brown is for multibacillary. On the other hand, for adults, कौन सा हुआ? Green हुआ या pink हुआ multi के लिए? Reddish is more multi, right? So multibacillary is reddish color. So please remember 3 drugs for multi and 2 drugs for paucibacillary. Next is one of the latest. This is the recent indicators. Recent. I don't think this will be asked in your exam. This is not required. This is not required for your exam right now. You just should be knowing that what is the current prevalence. The current prevalence of leprosy is only, we are proud to say, it is only 0.45%. Not percent, it is 0.45 per 10,000 population. The current prevalence rate of leprosy is 0.45, and the ANCDR, that is the annual new case detection rate, is 5.5. It is 5.5 per lakh population. Grade 2 disabilities among the 10 lakh population or per million cases is the operational indicator. It is an indicator for early case detection. This has been asked in your MCQ. Cure rate, you can just leave it. It is epidemiological indicator. Early case detection is given by grade 2 disabilities among 10 lakh population. Please remember this. I would also like you to remember Leprosy Mukt Bharat program that was launched in year 2023. It is till 2027. You already know what is Sapna, beta. Who is Sapna out of these? Sapna is one on the girl on the right or girl on the left. What do you think? Who is Sapna? Who is Sapna? Sapna is the girl on the right or on the left? So yes, absolutely correct. Sapna is with a school girl. It is with a school bag. Sapna goes to school. S for Sapna, S for school. S for Sapna, S for school. School going girl child is this one. So who is Meena? Meena is this with a parrot. Meena is with a parrot. So ANCDR we have already done is 5.5. Leprosy prevalence is 0.45. Welfare allowance for leprosy has been increased. But these are all Leprosy Mukt Bharat points. These are all points from Leprosy Mukt Bharat. This was launched in year 2023 till 2027. It is a 5-year program which was launched. Let's go to the next MCQ. A forest officer was given a pre-exposure prophylaxis 2 months ago and now comes to your health and wellness center with unprovoked bite by a wild dog on his leg. So now the question says a forest officer was given a pre-exposure prophylaxis 2 months ago. When did the person take prophylaxis? 2 months ago. Now comes to your hospital with a dog bite. What are you going to do? Will you give only wound management? Give anti-rabies vaccine and wound management? Give rabies immunoglobulin, ARV and wound management? Give rabies immunoglobulin and wound management. So what do you think? Which of the following is the correct one? See beta, you should be knowing that there are different classes of class bites. So in class 1 bites, what are class 1 bites? What are class 1, class 2 and class 3 bites? Class 1 bites are simple licks or touch. Hai na? What are class 2 bites? These are lacerations or cuts. And what are class 3 bites? These are deep tissue injuries. Deep tissue injuries or blood oozing, or please also note that it is licks on mucosal surface. So licks on mucosal surface is also a class 3 bite. So what do you do in a class 1 bite? It is only wound management. What do you do in a class 2 bite? It is we give the anti-rabies vaccine. What do you do in class 3 bites? We give the anti-rabies vaccine plus the rabies immunoglobulin. That is the general types of classification of animal bites. Now coming over to what are the different regimes. How many types of different regimes are there? Beta, we can have these 4 regimes. कौन सी 4 regimes? We can have re-exposure prophylaxis, pre-exposure prophylaxis, thigh and SN. What is thigh and SN? They both are types of post-exposure. They both are types of post-exposure prophylaxis. Okay, they both are types of post-exposure prophylaxis. So how many visits, how many doses, and how many what are the routes? So how many visits in re-exposure? Re has 2 alphabets. There are how many visits? 2 visits. Pre has how many alphabets? PRE. It has 3 visits, 3 alphabets. THAI, 4 visits. ESSEN, 5 visits. So it's simple to remember the number of visits. Doses. Re-exposure is 2 doses. Pre-exposure is 3 doses. Thigh is, please remember, thigh is 8 doses. Thigh is 8 doses. And post-exposure for SN, it is 5 doses. Okay, what is the route? This could be given as intradermal or it can be given as intramuscular, intradermal or intramuscular. Thigh is always intradermal, SN is always intramuscular. Okay, so please remember thigh is always intradermal, SN is always intramuscular, 5 visits, 5 doses, SN schedule. Rabies immunoglobulin should be given to all cases of class 3 bites. Please note rabies immunoglobulin is not given in case of re-exposure or pre-exposure prophylaxis. It is not given in case of re-exposure or pre-exposure prophylaxis. So now this patient is coming for re-exposure prophylaxis. Under what situations are you going to give the re-exposure prophylaxis? Re-exposure prophylaxis, what are the indications? Please note indications for re-exposure. It is given to all previously immunized cases which took immunization, complete immunization more than 3 months ago. So that means more than 3 months ago अगर immunization लिया था, either pre or post, whatever they might have taken. They might have taken a pre-exposure, they might have taken a post-exposure. Any case of previously immunized, please note it is not the second time dog bite. Dog bite could be first time only. Na? Patient was a welfare officer, veterinary welfare officer, forest officer. He took a pre-exposure and then unfortunately got a dog bite. Will that be taken as a pre-exposure, na? Or a re-exposure or a post-exposure? So he got the dog bite for the first time, but he was previously immunized. So what are the indications of re-exposure beta? It is given to previously immunized. ऐसा नहीं बोलना, it is given to previous dog bite and now second time dog bite. People who had taken previous immunization, either pre-exposure or post-exposure, if they get a dog bite again, now if it was more than 3 months, we give the re-exposure. And please note, we have already done no RIG is required. No RIG is required. So if you understand all this, let's come back to the MCQ. Forest officer was given a pre-exposure prophylaxis 2 months ago. 2 months ago, and now comes to your health and wellness center after an unprovoked bite by the wild dog. Next step in the management is, what do you think is the next step in the management? Beta, next step in the management is to give them anti-rabies vaccine. And wound management, or only wound management, or rabies immunoglobulin, ARV and wound, or RIG and wound management? क्या बोलोगे? You say? So now he comes after 2 months. So within 2 months, 2 months. Please note, no re-exposure is required now. No re-exposure is required, so only wound management will be done in this case. Even if it was a class 3 bite or a class 2 bite, no anti-rabies is required because it was just 2 months ago. So he was already given a pre-exposure prophylaxis 2 months ago. They don't need it again. So that is the recent update by the NRCP, National Rabies National Program for Control of Rabies, NPCR, National Program for Control of Rabies 2019. These were the guidelines. These were the guidelines. Beta Amit Mittal, it is not B. It is not B. Correct answer is option A. क्या बोलते हो? What do you think? It is option B or option A? It is option A only. Only wound management is required. However, if you still have a doubt, just let me know. We will talk about this question again. Coming to the next MCQ, a 40-year-old male presents to OPD with a wound which he got while opening an old storage box made up of metal 2 hours ago. The game of the story is 2 hours ago he got a wound. He states that he was given last TT immunization 5 to 6 years ago. The next best step in management is. So only wound management, give 1 TT vaccine and wound care. Give 2 TT vaccine with TT immunoglobulin. TT immunoglobulin immediately followed by a single dose of TT vaccine after 4 to 6 days is recommended. So what do you think is the best answer over here? What do you think is the best answer over here? So what do you think is the best answer over here? Beta, this question is directly from my PDF, which you will obtain in the Telegram group. In the Telegram group, one of an important resource I would like to say is you see for the 2-bite prophylaxis. You search for the 2-bite prophylaxis. So this contains TT prophylaxis, diphtheria prophylaxis, and it also contains questions from rabies prophylaxis. However, important for you is TT and diphtheria from this 2-bite prophylaxis. It is a PDF file. That's the name of the PDF. The PDF file is 2-bite prophylaxis. It's available in the Telegram group. So it's important. It's an important, like you can say, PDF over here. So what do you think you're going to give? In case of tetanus, we are going to give tetanus prophylaxis based on the category. We can have category A, category B, C and D. Category A patient is a patient who has taken within 5 years. B is more than 5 years but within 10 years. C is more than 10 years ago, and D is cool dude patient who is not known, everything is okay, he's the god. So he doesn't know about his immunization status. So now what is this case? This patient is saying that his this person had taken a TT immunization 5 to 6 years ago. So common sense, this person is category B case. So this person is category B case. So in category A, we give only wound care. In category B, we can take the clean wound, we give wound care plus single TT. Even in unclean wounds, if the patient is category C only, then we give TT immunoglobulins in category C and D. Okay, so please make sure you study this topic and go. It is important 3 by 5 star MCQ topic, frequently asked in your exam. So as per this understanding, if you just look at this, so now this patient had taken a wound 2 hours ago. So this is a clean wound. It will be classified as a clean wound, and it was done. The patient had taken immunization 5 to 6 years ago. So what is this? This is category B patient. This is category B patient. So what are we going to give? 1 TT vaccine and wound care is the best answer over here. Next question, a female has right to good quality of delivery services and no health institute can deny care to the pregnant female. Right, good quality care of delivery services and no health institute can deny care to the pregnant female is safeguarded under which program? So what do you think? It is safeguarded under which program? It is safeguarded under PM Surakshit Matritva Abhiyan, PM Matru Vandana Yojana, Surakshit Matritva Ashvasan, or Janani Shishu Suraksha Karyagram. What do you want to say? A female has a good right to good quality of care. Right of good quality care and no denial of services. Please note that the best answer over here, this is for Suman scheme. Do not get confused. It is for Suman scheme. Surakshit Matritva Ashvasan. What is Suman scheme? Suman scheme. Suman scheme stands for Surakshit Matritva Ashwasan. So please note that this is Suman scheme. You can see over here Suman. Suman is for giving free healthcare. It is for all pregnant females. It is for all infants who are sick. Infants who are sick. Please note that this Suman scheme, it is basically an umbrella scheme. It is an umbrella scheme to give good quality of healthcare and zero tolerance for denial of services. Denial of services. For denial of services. So absolutely correct. Everybody's answered this question on mother and child health absolutely correctly. It is option C, Surakshit Matritva Ashwasan scheme. Please remember this is Surakshit Matritva Ashwasan. Ashwasan means a guarantee scheme. Let's move to the next MCQ. So Ashwasan is guarantee. Sir, can you provide a PDF for this live lecture? Yes, of course, Niyati. I will be providing the PDF in the Telegram group. You can download that PDF from the Telegram group. And Mustafa Ahmed, do you have any document? Beta, I am the document. I have given so many times this document on health program. It's there when we conducted the quiz. You search the Telegram group, Beta Mustafa, you will find it. So I think your document, what you're looking for, is already there in the Telegram group. Coming to the next MCQ, screening of female for any disease and the high-risk pregnancy is done under what program? It is done under what program? Pradhan Mantri Surakshit Matritva Abhiyan, Matru Vandana Yojana, Surakshit Matritva Ashwasan, Janni Shishu Suraksha Karyagram. What do you think? What do you think is the best answer over here? Screening of females for any disease. Screening of females for any disease is there available under which program? Please note that screening of female for any disease and high risk pregnancy, it is done under the Surakshit Matritva Abhiyan. Please do not get confused. This is Surakshit Matritva Abhiyan and we have a Surakshit Matritva Ashwasan. The only word over here is Abhiyan and Ashwasan. Surakshit Matritva is same in both the cases. It is Surakshit Matritva Abhiyan. So absolutely correct. It is PMSMA. Almost everybody is answering correctly. PMSMA. A one-liner about all these things. What is Lakshya program for? Lakshya is for Labor Room Quality Improvement Initiative. It is to improve the quality of equipment, services and devices in labor room. In labor room to improve the quality. So Lakshya is for quality of labor room. Lactation management centers, it is to promote breastfeeding. Not promote breastfeeding by the mothers, it is to promote breastfeeding or breast milk donation. So highlight the word, it is to promote breast milk donation. So in case the mother has extra breast milk, she can keep the milk for future use. In case the mother does not have a breast milk, she can take the breast milk which has been donated by other females, or in case the female has extra breast milk, which sometimes the child is no more and the mother is still having breast milk, using pumps they can donate the breast milk for other children as well. So lactation management centers, these are for breast milk donation. What is PMSMA? It is to find out females with high risk. Remember, PIH, if there is there in female, it is blue category. If it is healthy, normal, no problem, it is a green category. High risk pregnancies, it is what category? Red category. And in other diseases, except PIH, it is yellow category. So this is color-coded categorization under the PMSMA scheme. Mother's absolute affection, you already know, that is the MA scheme. MA is to promote breastfeeding in India. So what are the breastfeeding guidelines? Normal vaginal delivery, the breastfeeding should be done within 1 hour, at least within 1 hour. Of course, it should be done as soon as possible. In cesarean section, it should be done within 4 hours. Matru Vandana Yojana, it is cash incentive, not cash incentive, it is incentive to the female in case they get their proper ANC and immunization done up till 5,000 rupees. They will get cash up till 5,000 for the first born child. It is only for the first born child in case the child has completed first dose immunization. When do we have the first dose immunization? When is the first dose immunization? This can be your MCQ. It is done at 6 weeks. So first dose immunization does not mean the birth dose immunization. First dose immunization means the 6-week immunization. Mission Parivar Vikas, it is to promote family planning. Mission Parivar Vikas is to promote family planning, and that's all that you need for mother and child health. That's all that you need for mother and child health. Any doubts you have, you're most welcome to ask. Any doubts you have, you're most welcome to ask. Mission Parivar Vikas is for family planning. So just to have the look at the logos, you know that this is what? This is the Lakshya logo. Then you have is the Matru Vandana Yojana. We are giving 1000 rupees when the female does first ANC within 12 weeks. Then she will get 2000 rupees in case of institutional delivery, and complete ANCs, 4 ANCs are completed, then last 2000 on the first dose vaccination. Absolutely correct, Mohit, there. Very nice. So Ma is for promoting breastfeeding, and this is Surakshit Matritva Abhiyan. 9th of every month, free ANC. Free ANC. It is to find out the high risk pregnant females. Coming over to the next topic, that's all about the mother-child health. Mother-child health has been asked so many times in the exam, so I don't know if it's like very really important this time, but yes, this time the game of the story would be environment, epidemiology, COVID-19. What are vaccines in COVID-19? The next MCQ, INCOVAC, is what? What is INCOVAC? Viral vector vaccine, mRNA vaccine, killed vaccine, receptor binding protein vaccine. Please note that INCOVAC, what is INCOVAC? INCO stands for the incompetent vaccine. Incompetent vaccine. INCOVAC stands for the incompetent vaccine. So it is incompetent adenovirus vaccine. It is incompetent adenovirus vaccine. It is incompetent adenovirus vaccine. So GSY change in GSK. No, beta, there is no change in GSY. Sir, please clear difference between GSY. No, GSSK and Suman. There is hardly any difference. If you just Google this Suman program, you will find out that Suman is nothing very special. Suman is umbrella program. Everything is now clubbed under the Suman scheme. Everything is clubbed under the Suman scheme. So I'll just like give you the answer first for the Suman scheme. Beta, what is Suman scheme? Suman is umbrella program. It includes, it's a GSSK, like you can say it's the aggravated version, or it is advanced version of GSSK. Suman is bigger. GSSK with quality of care, with good services, and with zero denial is what is Suman scheme. Okay, there's no difference. GSSK is a smaller program. Now the government wanted to do something more. They incorporated GSSK under the Suman. Suman is an act. Okay. Next is, somebody asked me about the GSY. Cash incentive for GSY. It's a very old MCQ. I do not think it's not required for your exam. Agar hota required, I would have told you. But because you are anxious about it, please note that in rural areas, or we can have the urban areas. In rural areas, we can have 1400. In urban areas, it is 1000. And in rural areas, the Ashas will get 700. And in urban areas, it is 600. This is for the low performing states. This is for the low performing states. What do you mean by low performing states? Low performing states is where the TFR is still high, where the maternal mortality rates are still high. This is the incentive which is given to the mother, and this is the incentive which is given to the Asha worker. This is the incentive which is given to the Asha worker. In high performing states, it is very low, like it is 600 and just a moment. I'll just remake this GSY. Please note GSY incentive for ASHA. We can make it this way: ASHA and for mother. It is a high performing states or for low performing states. So incentive for ASHA in the high performing states, it is like everywhere it is 600 to 700, 600 to 400, 400 in case of urban areas and 600 in case of rural areas. 600 in case of rural areas. That is for ASHA. That is incentive for the ASHA. Now the mother incentive could be in low performing states. It could be in high performing states. Mother incentive for the high performing states in rural areas, it is 700. In urban areas, it is 600. Mother incentive for the low performing states in urban areas, it is 1100, and in rural areas, it is 1400. Okay, so that's what you just need to remember in low performing states and in high performing states. And in low performing states, the ASHA incentive are 600 rupees flat. So that is what we need to remember for GSY. It is old scheme. It has been taken over by the bigger daddy, that is the Prime Minister Matru Vandana Yojana. By the Prime Minister Matru Vandana Yojana, GSY is kind of older system now. GSY has been taken over by the Matru Vandana Yojana. One MCQ on GSY can come, that GSY is for which all people. It is for all females who are age more than 19 years and only up till 2 live births. It is only for up till 2 live births. So that's all. Any other doubt? Like NEET 2022 में आया था about the cash incentives. Yeah, cash incentives had been asked in NEET 2022, but I don't think they will ask. See, beta, what I always say is that there are some rare MCQs which will keep on coming. You can't study based on the rare MCQ. If one MCQ was in your INI set, if somebody asked you, I don't know if you have done the previous year question, you must have done. There was a question on reorder level. Was there a question on reorder level? Reorder level, when will you reorder the stuff? So the reorder level question is a kind of rare MCQ. I do not think it will be ever repeated again. It is done and dusted. Now there will be a new type of rare question. So these are like, of course, if you want, you can remember this, but mostly states are having some added benefits on these GSY, and that's the reason these questions are less likely to be asked. But yes, you should be knowing this. Let us move to the next MCQ, beta. What is Incovac? Incovac is viral vector vaccine, mRNA vaccine, killed vaccine, or receptor binding protein vaccine, or what type of Incovac is. Regarding the COVID-19 vaccines, this is what is a 7-star MCQ table for you. This is a 7-star MCQ table for you. COVID-19 vaccines. COVID-19 vaccines can be viral vector vaccine, point number 1. They can be killed vaccine, protein subunit vaccine, or the mRNA vaccine. Which are the 4 types? Viral vector vaccine, killed vaccine, protein subunit vaccine, or the mRNA. These are the most commonly used 4 types of vaccine. In the viral vector vaccine, we can have Covishield, which has been taken by majority of the global population. Covishield, also called as the ChAd-OX1 or the chimpanzee adenovirus or the AstraZeneca vaccine. AstraZeneca vaccine, this is the same answer, Covishield vaccine. Next is the Sputnik vaccine, that is human adenovirus vaccine. Say with me, Sputnik is what? Human adenovirus. Covishield is what? Chimpanzee adenovirus. Sputnik is human adenovirus. Covishield is chimpanzee adenovirus. Then we have is the Janssen. Nobody will ask you Janssen because it has been taken back. Viral vector vaccine by Johnson & Johnson. Then we had is the Incovac 2022. It is the BB, Bharat Biotech virus vaccine, 154 number strain. It is the nasal vaccine. This can be asked in your exam. This can be your prospective MCQ. BB154 nasal vaccine, Incovac. It has been given emergency use approval by the FDA, by the WHO, and it has been given approval by the ICMR, and it has been used in many places. Incovac as a booster dose vaccine, BB154 vaccine. Next is killed vaccine. Killed vaccine is Sinovac or a Covaxin. So Covaxin, I don't think anybody will ask you. Yes, Sinovac can be asked in your exam. Protein subunit vaccine, mostly under the Global Alliance for giving COVID-19 vaccine over the world, we are using Novavax vaccine, Novavax. Other vaccine that you can remember is Corbevax. Corbevax is again from India. Corbevax is also from India, and Corbevax BE Cov COV2D protein subunit strain with alum adjuvant. This is what is Corbevax. mRNA vaccines, these are Pfizer and Moderna. Just a recent advance for you that now the Moderna and Pfizer, they have started a bivalent vaccine. What do you mean by a bivalent COVID vaccine? That's a new term. That's a new term, bivalent COVID vaccine. Bivalent COVID vaccine is nothing but it contains the SARS COVID-1 vaccine, that is the Delta variant. It also contains the Omicron variant. So the Pfizer and Moderna, they are now available as a bivalent COVID vaccine. It's a huge business now. So which are the Indian produced vaccine? Which vaccines are the Indian produced vaccine? Beta, Indian new vaccines which have been incorporated is the Corbevax and the Incovac. Corbevax is a receptor domain binding protein vaccine. It is age group is 12 to 14 years. It has been approved for more than or higher. And 12 to 14 years or higher, it is given as intramuscular 2 doses with a more than 4-week gap. It is a recombinant subunit vaccine. These are protein vaccines. Yes, it is Indian vaccine. Incovac is also produced by Bharat Biotech. It is a replication deficient adenovirus. It is for age, currently approved for age more than 18 years, 2 doses with a gap of 4 weeks. It has been produced from India and in September 2022, and this was the latest Incovac and the Corbevax. Just a new update for you. It was launched in year 2022. So the 2022 updates may be important for you. That is a Zycov-D vaccine. What is Zycov-D? It is the only known DNA plasmid virus vaccine. It is the only known DNA plasmid virus vaccine that carries the gene for the spike protein, but it is a DNA vaccine. It is a DNA based vaccine. I know it might be astonishing for you, but mRNA vaccine and the DNA vaccine, these are for the first time mankind have ever started using mRNA vaccine. What is mRNA? That is a genetic material. So for the first time, you started using genetic engineering into the immunology sessions now. So earlier we were having viral vector vaccine. These are very common examples. Killed vaccines were again very common example. Protein vaccines were again very common example. But for the first time, we started using the mRNA vaccines and the DNA vaccines incorporated into system. Minimum age for COVID, there is no age. Even children can be vaccinated for COVID now, age more than 5 years. So which one is given in adult, which one in children? If it can be asked, no, it cannot be asked because the guidelines will keep on changing. So these are some things which we don't even know whether we are doing it right or whether we are doing it wrong. But yes, we cannot judge on this. This question can be asked, can we give the vaccines? Can Covishield or Covaxin be given to a pregnant female? Yes, they have been approved for pregnant females. Pregnant females, yes, these vaccines have been approved. Can Covishield or Covaxin be given to pregnant females? Yes, they have been approved for use in pregnancy, but with risk and benefit ratio. So coming back to the MCQ, Incovac is, what do you think is Incovac? What is Incovac? Incovac is incompetent adenovirus based vaccine. It is a viral vector vaccine. It is not a mRNA killed or a receptor binding protein. What was the receptor binding protein? That was Corbevax. Killed vaccine is Covaxin, and mRNA vaccine you already know is Pfizer and Moderna. Coming to the next MCQ, environment, entomology, and some other salient points from these topics. Flea-borne rickettsial disease is flea-borne. Flea-borne rickettsial disease. Beta, rickettsial disease is a very important 7 by 10 star MCQ topic, rickettsial diseases. Rickettsial disease freeborn, I am giving to you one single table. This one single table is pretty important and it can be asked multiple times in your exam. Single table for all the freeborn diseases. Remember, Rickettsia prowazaki is epidemic typhus. How did I remember? iPhone Pro. iPhone Pro. iPhone Pro. Rickettsia prowazaki. Rickettsia prowazaki. iPhone Pro is large. Remember, iPhone Pro is large. Rickettsia prowazaki is large and it causes epidemic typhus. iPhone, epidemic. It causes epidemic typhus. Remember, iPhone Pro is large. Remember, iPhone Pro is large. Epidemic typhus, Rickettsia prowazaki is large. It is louse-borne. L for large, L for louse. L for large, L for louse. Pro is for prowazaki. iPhone, IP, you can remember it as IP is epidemic typhus. Next is endemic typhus, murine typhus is Rickettsia typhi. It is the only flea-borne illness. It is the only flea-borne illness. This is pretty important. Flea-borne illness is Rickettsia typhi or a murine typhus. Flea-borne illness is the murine typhus. Out of all the vectors, beta, can you see all the vectors? Can you see all the vectors? Louse, flea, mite, tick, mite, none, and all these. Out of all these vectors, can you see that the only flea-borne disease is endemic typhus? That is murine typhus. Scrub typhus, Rickettsia orenchi or Tsutsugamushi, mite. You can remember it as mite or mate or your friend. Mate had to go for tsutsu in the shrubs. Mate had to go for susu or for urinating in the shrubs. I had to say this P word. So the mate, my friend, mate had to go for urinating for Tsutsugamushi. Where will that person go for urinating? In the shrubs. In the shrubs. In the shrubs. So remember, scrub typhus, Tsutsugamushi, mite borne. Remember, scrub typhus, Tsutsugamushi, mite borne. Rickettsia aurantia or Rickettsia tsutsugamushi is a mite-borne rodent and incubation period is 10 to 12 days. Drug of choice is tetracycline. Then is Indian tick typhus is Rickettsia conori. You can remember it as a tick-tock corner. You can remember it as a tick-tock corner. What is a tick-tock corner? Just remember tick-tock corner. Indian tick typhus is conori. Corner, conori. Indian tick typhus is tick-tock corner or conori. Indian tick typhus is tick-tock corner or conori. Rocky Mountain spotted fever, you can just leave it, Rickettsia. And rickettsial pox is like, you can just leave this. Q fever, Q is my favorite alphabet. Q is for queens. So queen, you can remember Q is a special alphabet. Can you see out of all the vectors? Can you see out of all the vectors, all have a vector except the Q fever. Q fever is a very special disease. Q fever beta is a very special disease. Q fever is a very special disease. Why is it a special disease? It is a special disease because it does not present with rash. It does not prevent with fever. It does not present with fever. And Q fever does not have vector. Everything is no. Q, queen. Queens are like special people. No rash, no fever, no vector, and it is a special kind of disease, Q fever. Trench fever is Bartonella quintana, louse-borne. Remember Bartonella quintana, that is louse-borne. Bartonella quintana, that is louse-borne. So rickettsial disease is again one of the very important MCQs which are coming in your exam, and this is a favorite question. It is a frequently asked question in your exam. Coming over to the next MCQ, late clinical failure in malaria is after 4 days of start of treatment, after 10 days of start of treatment, after 2 weeks of start of treatment, or after 1 month of start of treatment. Late clinical failure in malaria. Late clinical failure in malaria. So when do you say clinical failure? This is incorporated in this snapshot I have taken from the One Touch PSM book. Please note, when do you say a treatment failure? When do you say treatment failure? Beta, the treatment failure can be of two types, or basically it can be of three types. We can have early or late, and late can be further of two types: late clinical failure or late parasitological failure. I'll repeat again: treatment failure can be of three types: early or late. The late can be of late clinical failure or late parasitological. When do you say early? Early is within 4 days. Early is within 4 days if there is danger sign or the parasitemia persists, that is early treatment failure. Now, late failure is after 4 days. Late failure is after 4 days if the danger signs persist after 4 days, only danger sign, that is clinical. If there is parasitemia also after day 7, it is called as parasitological failure. So what did you understand, beta? This is the one touch PSM, bache. This is the one touch PSM book. So what do you understand in treatment failure? The treatment failure can be early, or the treatment failure can be late. Late could be clinical, or late could be parasitological. I don't think we need to discuss what is clinical and what is parasitological. Clinical means the patient had features, and parasitological means there were features there or not there, but the parasite was there. So early is happening of danger signs or parasites till 1 to 3 days, even with treatment. So if the patient has features, danger signs of malaria with parasites, even with treatment, 1 to 3 days. Clinical is after 4 days, and parasites is after 7 days. That's all that you need to remember for your exam. How many types of treatment failures? Two types of treatment failures: early and late. Late could be clinical or parasitological. So based on this, if you understand this, late clinical failure in malaria is after day 4 of start of treatment, yes. After 10 days of start, no. After 2 weeks is no. After 1 month is no. So what do you think? What do you think? What do you think is the best answer? It is, best answer is after day 4 of start of treatment. Thinking of a giveaway for One Touch, sir? Yes, we already gave away so many One Touch books. It was given off in the classes in Delhi when I conducted, and it was given online also on Valentine's Day. We gifted so many One Touch. I think more than 100 One Touch have been distributed till now. So for the Valentine's Day, it was given as special event. Coming to the next MCQ, which of the following is incorrect match? What do you think? Question from entomology. Again, question from mosquito. I think this was debated last night in the Telegram group. Which of the following is the incorrect match? Culex, egg in cluster. Anopheles larva, no siphon. Aedes mosquito, clean stagnant water. Sandfly is nocturnal, biting, plainful bite. Which is incorrect match, beta? Which one is incorrect? All these MCQs I have freshly prepared. They have not been taken from anywhere. These are all out of my mind, and these are MCQs from like direct from the desk. So Culex mosquito, eggs and cluster, yes or no? Anopheles larva, no siphon. Aedes is clean stagnant water, and sandfly is nocturnal biting. Which is incorrect match? What do you think about the incorrect match? This is again a table I am showing. This is a screenshot from my book, One Touch PSM. Again, I would like to say I'm very proud of this book. It is like very quick revision you will be able to do. I never felt I'll be able to do this concised PSM within 35 pages. It's a huge thing. I don't know how it happened. But anyways, I'm proud of my book, One Touch PSM. This table is from One Touch PSM, Anopheles, Aedes, Culex, Mansonia. These are the 4 types: Anopheles, Aedes, Culex, Mansonia. Anopheles causes, like it leads to what disease? Malaria. Aedes, dengue and chikungunya and yellow fever. Culex is Japanese encephalitis, lymphatic filariasis. Mansonia is lymphatic filariasis. Very quickly, you need to revise one word. Anopheles means sophisticated. Anopheles, remember, sophisticated. Someone coming from a very hi-fi posh locality in Mumbai or in Delhi. So page 3 people, all film stars, think of them, sophisticated people. They do boating in which water? They do boating in clean stagnant water, and they will always wear some floating devices. They don't need a siphon. They rest in inclined position, morning, evening biting, Painless bite, flight is 2 to 3 kilometers. Aedes. Remember, Aedes is a kind of a very fearless mosquito. It is a fearless mosquito. Why do I call it as a fearless mosquito? Because it lives inside our houses. Remember, it lives inside our houses. It is endophilic. It is endophilic, it is inside houses. If it is inside houses, of course, the flight will be only 100 to 200 meters. It will live inside your house. It will do yoga parallel to the ground. I don't know why there was confusion regarding this point yesterday in the Telegram group. Aedes mosquito is parallel to ground. That is correct. Aedes mosquito is parallel to ground. The resting position is parallel to the ground. The body of the mosquito is parallel to ground. The body of the Anopheles mosquito is inclined. The body of the Anopheles mosquito is inclined. The body of the Aedes mosquito is parallel to the ground. It bites you during daytime. It is a fearless mosquito. It's like zoop, it'll come and bite you, and a painful bite. And it is in cigar shaped eggs, single eggs, artificial stored water. It will stay in your house. It will bite you during daytime. It will drink your water, artificial stored water. It will do yoga in front of you. That means parallel to the ground. And it is as fearless as a tiger with stripes on the body and also on the legs. Culex mosquito, it is a dirty mosquito. You can remember this as a dirty mosquito. Why do we call this as a dirty or a nuisance mosquito? Because it lives in which water? It breeds in dirty, polluted water. If the Culex was hearing me sometime, it will come and attack me because we are saying bad things about it. It is dirty, polluted water, and it is eggs in clusters and rafts. There is siphon. Please remember, all larvae will have siphon except Anopheles. Adult is hunchback, midnight biting. It stays inside, outside both. It is the only one with brown color of the body. Very important. Remember, it's a dirty mosquito, brown color mosquito. It has big wings, and it is also called as a nuisance mosquito. If I just want to show you the larva, many students get confused over this. The larva for Aedes, can you see the over here? What is this? What is this structure, Bitte? What is this structure? This structure is what you call as the siphon. What is siphon? It is the respiratory tube. And where is the respiratory tube connected? It is connected towards the anal end of the mosquito larva. Please note, they are not humans, right? So they don't have the structure like a human. The siphon is a respiratory tube, and it is connected to the anal end of the larva. Anopheles is the only one where the siphon is absent. There is no siphon. Culex also has a very long siphon. Culex has a very long siphon. So Aedes has a siphon, Culex has a siphon, and they are at the anal end of the mosquito larva. You can see the eggs over here. Whose eggs are these? These are in rafts. Rafts are in clusters. So what is this egg? This egg is from the Culex mosquito. This egg is from the Culex mosquito. Let's have a look at it more. So if you see the Aedes mosquito is kind of sitting parallel. Anopheles is always inclined. And Culex is always hunchback. Hunchback. Anopheles is inclined. This diagram I would not say is a correct diagram. This diagram is not a very correct diagram. The Anopheles mosquito with the head down and the tail is up. The tail is up in the air. Remember, anus, Anopheles. Anus is OP, up. Anus is up. Remember, Anopheles is up. Aedes is parallel. Aedes is parallel. Culex is hunchback. Culex is hunchback. Say with me. Culex is hunchback. Anopheles, anus is up. Anus is up. And Aedes is parallel. Aedes is parallel. There is no siphon. There is a long siphon. And there is a short stump siphon. But is there a siphon in Aedes? Yes, there is a siphon in Aedes. Is there a siphon in Culex? Yes, there is a siphon in Culex. And there is no siphon in Anopheles. Aedes has DE in it, can be used to recall that it causes dengue. Very nice. So dengue, Aedes, dengue. Very nice. What is this insect? What is this insect? This insect, whenever you see lot of hair on it, whenever you see Anil Kapoor, lot of hair on it, lot of hair, I'm sorry for taking the names. Hair on the insect, hair or insect, very hairy insect, very hairy insect. Think of sandfly, sandfly, hairy insect, sandfly, hairy insect. Anil Kapoor like sandfly, hairy insect, sandfly, hairy insect. Lot of hair on the sandfly, and he's very ferocious. He or she is very ferocious, and they are having a very painful bite, painful bite, very painful bite. Where would the sandfly bite usually? What is the flight range of the sandfly? Remember, sandfly is the only fly which does not fly. Sandfly is the only fly which does not fly. So what does it do? It only hops, it only hops, it only jumps. How can it jump? Because it has long legs. Long legs. Sandfly is the only fly which does not fly. It only hops. Sandfly only hops. How much is the hopping range? 50 yards. Sandfly has a 50-yard hopping range. Hairy insect, Anil Kapoor, painful bite, only bite during night time. Majority of the bites are nocturnal bites, painful bites. And these are very important features about sandfly. Sandfly leads to what disease? Kala Azar. Sandfly leads to Kala Azar. Okay. So that's all about this MCQ. So which of the following is incorrect match? Anopheles breathe कैसे करता है बेटा? Anopheles larva will be very close to the surface of water, and when it is close to the surface of water, when the Anopheles larva is close to the surface of water, it breathes through the surface of the water. So it breathes through the surface of the water. Which of the following is the incorrect match? Culex is in eggs in cluster. Yes, this is correct. Anopheles larva no siphon. Yes, this is correct. Aedes mosquito has clean stagnant water. This is wrong. It is an artificial stored water. It is an artificial stored water. Beta, clean stagnant water is for what disease? Clean stagnant water is for Anopheles mosquito. It is not for Aedes mosquito. Sandfly nocturnal biting. Yes, this is correct. Which of the following is the best answer? The best answer over here is Aedes mosquito. The best answer over here is Aedes mosquito. Okay. Let's move to the next MCQ. Identify the following. A little bit MCQs about the image-based questions, and yeah, I think we have around 5 or 10 more MCQs, and that will be all for the day. Identify these insects. Question number, point number 2.1. What do you think is this? What is 2.1? 2.1. Whenever you see beta, whenever you see a round, or round, it could be a mite, it could be a hard tick, it could be a soft tick. So what is the difference between them? The difference between them is that there are 4 legs in a mite. There are 4 legs in a mite, and surprisingly there are 4 legs in a hard tick and 4 legs in a soft tick. So how would you differentiate? In the mite, the legs are very thick legs. The very thick legs are there in the mite, and the legs, they help attached to the skin, this is itch mite, this is itch mite. So how does the itch mite look? It will have very thick legs, it will have very thick legs, very thick legs is the feature of itch mite. How would you differentiate between a hard tick and a soft tick? Whenever you see a head, if you see a head tick, you can remember as a hard tick. H for head, H for hard. So if you see a head, it is called as a hard tick, and if there is no head, it is called as a soft tick. So very nice. If you just remember what is mite, what is tick, and what is soft tick. Hard tick and what is soft tick. What is hard tick and what is soft tick. Next in line, sometimes examiner may ask you what is a louse. L for louse, L for long. L for louse, L for long. It is elongated structure. The point is, it has only 3 legs. It has only 3 pairs of legs. It has only 3 pairs of legs with claws. There are claws on the louse. L for louse, L for long, 3 legs. How many legs are there in ticks and mites? It is 4 legs. 4 legs in ticks and 4 legs in mite. So just look at this. How many legs are there? Thick anterior legs and thick posterior legs. This is what is itch mite. Itch mite. This we have already done. It is sandfly. What is 2.3? 2.3 stands for, like the image is for hard tick. Why do we say hard tick? Hard tick we say because we see a head. Can you see the head? Whereas 2.4, can you see there is no head? Because there is no head, this is a soft tick. This is a soft tick. What is 2.5? 2.5, you can see L for louse, L for long. You can see a louse over here. Long insect, that is louse. You can remember this as louse. Remember this as louse. Okay. I have a doubt in waste category. Beta, you can just shoot the doubt in the chat box and I'll be seeing it very often and I'll be able to answer your doubt. Anyways, we do have questions from biomedical waste also. Which of the following is not a part of the global hunger index? What do you think? Which of the following is not a part of the global hunger index? What do you think? Which is not a part of the global hunger index? What do you think? Which of the following is not a part of the global hunger index? Under 5 mortality rate, malnutrition rates, inadequate food supply, income as a percentage of GDP. So beta, global hunger index, you need to remember 3 points. What is HDI? What is PQLI? And what is GHI? What is HDI? HDI is Human Development Index, PQLI is Physical Quality Life Index, and GHI is Global Hunger Index. I am giving to you a very smart summary table for all the 3 indices. This is a 7 by 10 star MCQ for you. So please note that you do this and go for your exam. Please remember that you do this and go for your exam. We are talking about the PQLI, HDI and the GHI. PQLI is Physical Quality of Life Index. It takes into account 3 indicators. Life at 1 year. Please remember life at 1 year. How will you remember 1 year? PQL1. Remember PQL1. Literacy rate and infant mortality rate. Human Development Index, it takes into account 4 indicators: life expectancy at birth, mean school years, expected school years, and GNI. MCQ over here, GNI. It is not GDP. It is income as a part of the GNI and not GDP. GNI stands for the gross national income. Global Hunger Index, it takes into account 4 indicators: under 5 mortality rate, undernutrition in terms of wasting, stunting, and inadequate food supply. The national data for India, it shows that the Human Development Index is now 0.63, 0.63 or 0.64. Rank is 132. Whereas the Global Hunger Index shows for India is 29.1. It shows a serious hunger. India ranks at 107 out of 122 countries. So Global Hunger Index is definitely a major problem in the country. So this is the latest news. India in serious category in rank 107. This is the latest news for the Global Hunger Index. So what is Global Hunger Index? Is it arithmetic mean, geometric mean, or harmonic mean? It is a simple average. It is a simple average or the arithmetic mean. It is a simple average or the arithmetic mean. Beta, what is HDI? HDI is a geometric mean. HDI is a geometric mean of all the 4 indicators. That is another difference. Global Hunger Index is a simple average, whereas HDI is a geometric mean out of all these indicators. Next in line is find the incorrect match of the WHO regions with the regional headquarters. So what do you think is this? Answer: find the incorrect match of WHO regions with the regional headquarters. Africa, Brazzaville, Republic of Congo. Western Pacific, is it in Philippines, Manila? Eastern Mediterranean in Cairo, Egypt, where you have all the pyramids. Southeast Asia, everybody knows, is in New Delhi. Everybody says this is correct. Europe is in Geneva, Switzerland. America is in Washington, DC, United States. So which of the following you think is incorrect? You have to find the incorrect match. So what do you think is the best answer over here? Incorrect match of the WHO regions with regional headquarters. So which is the incorrect match of the WHO regions with the regional headquarters? Regional headquarters. So what do you think? What do you think? Which of the following is the incorrect match? Incorrect match. I'm waiting for your answers. Which of the following is the incorrect match for the WHO regions? Beta, yes, I think most of you have got it okay. There are 6 WHO regions, as you can see on the screen, 6 WHO regions. We have the region, first is the region of the Americas. The region of the Americas has the headquarters in Washington, D.C. They have the headquarters in Washington, D.C. Then you have is the second is the region of Africa, where the headquarters is in Cairo, Egypt. It is in Cairo, Egypt. Mediterranean, it is in Congo. Second is Africa. We were doing Africa, that is in Congo. Mediterranean is in Cairo, Egypt. Cairo, Egypt. Third is for Southeast Asia, that is New Delhi. New Delhi. New Delhi. Next is for Western Pacific, that is in Manila. Philippines. Philippines. Surprisingly, for Europe, it is not the region of Europe. The region of Europe, which includes Russia also, okay? The region of Europe is not Geneva, Switzerland. It is in Denmark, Copenhagen. Copenhagen is the Denmark is the headquarters for WHO region of the Europe. So which of the following is the incorrect one? Please remember that the incorrect one is not Europe, Geneva, Switzerland. That is the incorrect. It is Copenhagen. Copenhagen, that is for Europe, that is the incorrect one. So WHO can be asked in your exam. WHO is pretty important and can be asked in your exam. One other student asked me to talk about a little bit about the national programs which are being funded by the different agencies. United Nations, not the United States, the United Nations, especially the UNICEF, is working for many health programs which include the school applied nutrition program. UNICEF is also working for the national immunization. Sir, the word South American countries can be counted in Americas. Yes, it is the continent of Americas. Yes, it is the continent of Americas, beta. Yes, it is the total America. It includes the South America and the North American continent. UNICEF, it is for school applied nutrition program. It is also working for the national immunization program and for most of the nutritional programs in the country, which include the nutritional mission, which include the Poshan Abhiyan, the Poshan Scheme, United Nations. You should also know that TB program, it has funding from the SIDA, that is the Swedish International Agency. You should also know that the blindness program, NPCB, it has funding from the Danida, that is the Danish assistance. It is from the Danish assistance, Danida, Denmark, Danish International Development Agency, that is supporting the NPCB blindness program. TB is by SIDA. The family planning program is by both United Nations. It is by the World Bank. The TB is also funded by Bill and Melinda Gates Foundation. Most of the rural upliftment, most of the rural development is by the Rockefeller and the Ford Foundation. Rockefeller and the Ford Foundation, they are working for rural development in India. So that's like mostly grossly the bigger things. Malaria program is funded by the World Bank. World Bank and WHO is funding the malaria program, the National Vector-Borne Disease Control Program in India. So coming to the next MCQ, which of the following is a good indicator for burden of disease? This is seriously one of the most high rated MCQs because of so many doubts in this. Because of so many doubts and controversial responses given by different faculties. Anyways, with due respect to everyone, which of the following is a good indicator for burden of disease? But if they ask you burden of disease, the answer has to be DALI. There's no way you can answer anything else. So what are these indicators? A very quick review. We are talking about 3 indicators, DALI, QALY and HALE. We are talking about 3 indicators, that is DALI, QALY and HALE. What is DALI? DALI stands for Disability Adjusted Life Years. QALY stands for Quality Adjusted Life Years. HALE stands for Health Adjusted Life Expectancy. The point to be noted is that there are DALY and QALY stands for Disability Adjusted Life Years, Quality Adjusted Life Years. Whereas HALE, it stands for Health Adjusted Life Expectancy. DALY, it is a composite indicator which takes into account two things, that is years lost to life, that is premature deaths, and years lived with disability, that is the disability years. So DALY is the best measure for what? It is the best measure to measure the disability or the burden, or I can say the seriousness, or I can say the impact of a disease. The sequelae of a disease or the impact of the disease or burden of a disease or the seriousness of a disease is given by DALY. How bigger the disease is. People who got COVID and people who got Omicron, there was a difference in when COVID-19 was there in the world. If somebody got COVID, were you scared that my relative, my uncle, aunt, anybody, or I know this person, he got COVID, I don't know what's happening. Hey, how are you doing? We were scared with COVID-19 Delta variant. Yeah. Now, after 2 years or 1.5 years, now there is Omicron. So we say, hey, how are you? You got Omicron? Okay, I also got Omicron. Everybody is laughing about Omicron, right? So what happens to the seriousness of the disease? People earlier, they were having scare like about COVID-19 because people were losing lives and people lived with disabilities with COVID-19. So the burden of a disease, or how bad the disease is or how serious the disease is, that is what is DALY. What is QALY beta? QALY is quality adjusted life years. It is entirely different from what is DALY. QALY is the number of quality years. It is the number of quality years gained as a result of intervention. What is the use of QALY? QALY is the best measure to assess the impact of intervention. It is the best measure to assess the impact of the intervention. That is what is QALY. What is HALE? HALE is the beta life expectancy. You were born in India. I am born in India. There is my friend who was born in Japan. My another friend was born in UK, London. My friend was born in US or in Canada. So listen, number of healthy years the person will live in the country. In India, number of healthy years the person is bound to live in Japan. The number of healthy years. What do you mean by healthy years? Healthy years means free from disability. No diarrhea, no pneumonia, no COVID, no cancer, nothing. Free from disability. How many years I'm going to enjoy my life? Number of years the person is going to enjoy the life living in a country or a community is given by the HALE. HALE is one of the best measure to assess for what? Burden of all disease in the country, or in very simple language, it is the best measure to assess the health status of the population. It is the best measure to assess the health status of the population. That is what is HALE. So best measure to assess the burden of a disease, burden of a single disease is DALY. Impact of intervention is QALY. Health status of the population, or how people are living, it is because it is life expectancy. The best measure to compare health status among the population or the health services in the population is to check for the HALE. HALE is one of the superior rest indicator. But if the question comes, how to check for the burden of disease, it is DALY. Do you understand what the question is? If I say burden of all diseases in Myanmar were compared with the burden of all diseases in Guatemala, what indicator are you going to use? I will use HALE. But if you were assessing, I want to find the burden or impact of a disease like leukemia compared to impact of a disease or burden of a disease on a person, leukemia compared to Guillain-Barré syndrome, what should I take? We take DALY for Guillain-Barré, DALY for leukemias. Do you understand? DALY is like DALY for every disease in a community. Coming to the next MCQ, the following symbol is the following image is a symbol for Poshan, ICDS, Suman, or Jan Aushadhi. So, what do you think? Following image is a symbol of Poshan, ICDS, Suman, or Jan Aushadhi. The following symbol is direct question, direct answer. It is a symbol for Poshan. What is Poshan? Poshan beta stands for Pradhan Mantri Overarching Scheme for Holistic Nourishment. Poshan stands for Prime Minister Overarching Scheme for Holistic Nourishment, POSH, POSHN, Poshan. The Poshan scheme works to, the portion scheme is working to reduce, the portion scheme works to, uh, sorry for you can't see it. Okay, now it's better. Okay. So portion scheme or the Poshan Abhiyan, what is the use of Poshan Abhiyan? It is to decrease, remember 2 points only. Poshan Abhiyan is to decrease malnutrition in children, and Poshan Abhiyan is to decrease anemia in children. Malnutrition, how much to decrease? More than 2% decrease, more than 2% reduction every year, and anemia should be more than 3% reduction per year. You have to remember this. What is Poshan Shakti Nirman? Poshan Shakti Nirman is under the Ministry of Education. First MCQ. It is under the Ministry of Education. So, under Education Ministry, they are giving what? They are giving midday meals. Midday meal is for Bal Vatika and class 1 till class 8 student. It is for Bal Vatika students along with class 1 to class 8. What are Bal Vatika students? These are the pre-nursery. Question number 2 is who are the eligible. Point number 3, how much calorie, how much protein. Point number 3, how much calorie, how much protein. Please remember, primary class 450 calorie, upper primary class we are giving is 700 calorie. Protein is how much? 12 gram to 20 gram, 12 gram in children and 20 gram in elderly, like more older children. So for upper primary class we get 20 grams of protein. So remember these two, like what is Poshan Shakti Nirman and Poshan Abhiyan? Sir, which criteria to include, exclude in quali? These questions are a bit tough. Please simplify. I already told you, beta. If you get a, so did you get this question about Poshan Shakti Nirman and Poshan Abhiyan? These are two important things. Beta, in quali and Delhi, it is very simple. If the question says how to assess, direct MCQ, beta, there's nothing to get scared of. Assess impact of intervention. What will you mark? Quali. Burden of disease, or if case the question says seriousness of disease or impact of disease, it is all given by Delhi. How would you find out HALE? What is the use of HALE in your MCQ exam? HALE is the best measure to ascertain the health status of the population, health status of population. It is the best measure, it is the positive indicator to find the health status. It is to find the burden of any disease or all diseases in any or all diseases in the community or population. In the community or population, which of the following is a good indicator for burden of disease? It is A. That's all. It's pretty simple. Next MCQ, identify the following logo. The image is a symbol of mental health program, iodine deficiency disorder control program, anemia mukt Bharat, or baby friendly hospital initiative. The following image is what? It is a symbol of what? Please remember that the following image is a symbol of mental health program, iodine deficiency, anemia mukt Bharat, or baby friendly. It is for iodine deficiency disorder control program. Very important logo, and this is like a new type of smiley logo is there. This is NIDDCP. It is for NIDDCP, National Iodine Deficiency Disorder Control Program. So a quick review about the NIDDCP. What are the iodine levels in salt? Iodine levels in salt at the production level, it should be always more than 30 parts per million, and at the consumer level, in your and my home, it should be more than 15 parts per billion. Please remember that the goiter rate in the community, what are the levels of indicators in the goiter program? The indicators are that the goiter rate should be less than 5%. Urinary iodine excretion rate, it is one of the important principal impact indicator. It is also the most important epidemiological indicator. Neonatal hypothyroidism rates, these are the best indicators for environmental iodine deficiency. Environmental iodine deficiency is given by neonatal hypothyroidism rates. And last is iodine in household salts. This has been asked so many times. It is a process indicator or a operational indicator. It is a process indicator or an operational indicator, iodine in household salt levels. Coming to the next one, moderate malnutrition. So what is the answer to this? This is direct answer. I think most of you must have answered it correctly. Yes, it is option number B. Coming to the next MCQ, moderate malnutrition is shown by which zone on a growth chart? White zone, green zone, yellow zone, red zone. Moderate malnutrition is shown by which zone on growth chart? What do you think on growth charts? Moderate malnutrition. Moderate malnutrition, beta, is shown by which zone? Mild to moderate malnutrition. Mild to moderate malnutrition is shown by the yellow zone. Severe malnutrition is shown by the red zone, whereas a normal nutritional status is shown by the green zone. You should also know that in a few points about the growth charts. Growth charts. Very quick review about the growth charts. Growth charts we can have from +2 standard deviation to -2 standard deviation. This is the green zone, that is a normal zone. Then from -2 standard deviation to -3 standard deviation, it is the yellow zone. And from -3 SD below it is the red color zone. So what is yellow? It is mild to moderate malnutrition. Absolutely correct. Everybody is answering it correctly. So it is yellow zone. It is the C. Red is the severe malnutrition. You should also know that what is a severe acute malnutrition? SAM child. SAM is where the weight for height is less than -3 standard deviation. Plus there is mid upper arm circumference which is less than 11.5 centimeters. Plus there could be pedal edema. Pedal edema, which is bilateral pedal edema. So severe acute malnutrition, bilateral pedal edema, mid upper arm circumference less than 11.5 and weight for height less than -3 standard deviation. What do we do to these SAM children? We send them to NRC. What is NRC? Nutritional Rehabilitation Center. In the NRC, in the first phase, that is the stabilization phase. In the first phase, that is the stabilization phase, we are going to give a F75 diet. F75 means how many calories? 75 kilocalories. Then is the second phase, that is the transition phase. In the transition phase, we are going to give which diet? F100 diet. What is F100? That is 100 calories. F100 diet is also called as the catch-up diet, whereas F75 is what is called as the starter diet. F75 is what is called as the starter diet. Transition phase, F100 is what is called as the catch-up diet. Last is the third phase. Third phase is home-based diet, also called as the maintenance phase. Maintenance phase is where we give a home-based diet. Beta, NRC is expected MCQ. You should be knowing about NRC and SAM because we had a global hunger index of so poor or serious hunger, that is 29.1 global hunger index. SAM child and NRC, you should be knowing what is SAM child. SAM is severe acute malnutrition where the weight for height is less than -3 standard deviation, mid upper arm circumference less than 11.5 centimeters and pedal edema bilateral you will be seeing in a child. So NRC, Nutritional Rehabilitation Centers, and severe acute malnutrition is one of the high risk areas and high yield topics for you in your exam. You should also note how to, one of the student had asked me like any trick to remember. Niyati says chronic stunting, height एक दिन में नहीं पड़ती. बिल्कुल ठीक है. Yeah, that's what it is. So we have beta weight for age, weight for height. एक ट्रिक सुन लो ना, फटाफट से सुन लो. वेट फॉर एज, वेट फॉर हाइट एंड हाइट फॉर एज एंड हाइट फॉर एज. व्हाट इज वेट फॉर एज? बड़े सिंपल सी बात है. व्हाट इज वेट फॉर एज? वेट फॉर एज इज अ जनरल मार्कर फॉर जनरल अंडर न्यूट्रिशन. जनरल माल न्यूट्रिशन इज गिवन बाय वेट फॉर एज. Weight for height is a marker for acute malnutrition and height for age is a marker for chronic malnutrition. Simple सी बात है, height बंदे की, the person's height with 2 days of diarrhea or 3 days of diarrhea, height is not going to decrease, right? If somebody gets a diarrhea acutely, उसको एकदम से profuse food poisoning होगी, what will happen to the weight for the height? The height is going to be same, the weight is going to decrease. It is a very sensitive marker for acute malnutrition. Whereas chronic malnutrition is given by height for age and general malnutrition is given by weight for age. General malnutrition, what is the classification we use is Gomez classification. Acute and chronic is measured using the Waterloo's classification. What is the cutoff criteria in Waterloo's? This can also be asked. It is -2 standard deviation. Any child who is less than -2 standard deviation will be called as low on Waterloo's. So if the child is weight for height low, it is called as wasting. If the child is low height for age, it is called as stunting. So height less than -2 standard deviation, height for age less than -2 is stunting, weight for height less than -2 is wasting. This is what is Waterloo's classification. ठीक है जी? So that was just a small way to remember. And what is the criteria at this point? It is +2 standard deviation, or this is 95 percentile. And then we have is the -2 standard deviation. Then we have is the -3 standard deviation. These are the indicators. And a simple question. This is again a 5-star important MCQ topic for you. Moderate malnutrition is shown by which zone? The moderate malnutrition is shown by the yellow zone. Moderate malnutrition is shown by the yellow zone. Coming over to the last topic, that is demography and occupational health. Last points, demography and occupational health. Which IUD is available in a PHC or in a subcenter? What do you want to say? Which IUD is available in a PHC or in a subcenter? Progestasert, Mirena, copper T 250 or copper T 375? Which intrauterine devices is available in a PHC or in a subcenter? Progestasert, Mirena, copper T 250 or copper T 375. Please remember that whenever a female will come to us in the subcenter or in a PHC, we already have some of the nationally available contraceptive devices. So at a sub-health center, we already have some of the devices like the barrier methods. We already have the intrauterine devices. At a PHC or a CHC, we can also do tubectomy. We also have tubectomy, vasectomy. We also have some of the other contraceptives like Antra, Chaya. What is Antra? Antra is intramuscular injection. What is Chaya? It is Centchroman. What is Chaya? That is Centchroman. So these are the available contraceptives under the Mission Parivar Vikas. Mission Parivar Vikas. What is Mission Parivar Vikas? It is a mission to promote family planning. We already have barrier methods. OC. Oh, we forgot about the OC pills. Of course, OC pills are also there. OC pills. So we have barrier, IUD, tubectomy, vasectomy, OC pills, Antra, Chaya. These all are available at the PHC, CHC subcenters. Barrier, IUD are the only one which are available only at a sub-health center. Now point for you, important point is what is I-pill and what is easy pill. I-pill and easy pill, they both are emergency contraceptive. They contain 1.5 milligrams of levonorgestrel. They should be given, they should be started within 72 hours of unprotected intercourse. So now MCQ comes as which of the following intrauterine device is available at a PHC or a subcenter? Answer is copper 375. It's not a copper T, it is a copper 375. And we also have copper T 380. Very few salient features about each of them. What is copper 375 and copper T 380? Copper 375 and copper T 380. So please remember that copper T 380, it has a polyethylene thread, and there is a insertion tube, there is a plunger rod, and this copper T 380 is valid for how many years? It is valid for 10 years. Copper T 375 beta, it is valid for 5 years. There is a monofilament nylon thread, and please note there is no plunger rod. There is no plunger rod. There is just an insertion tube which is there with the copper 375. It is valid for 5 years. Any updates we should be knowing regarding Norplant, since it's a hot topic? I don't think it's a hot topic, Niyati. I don't actually think it's a hot topic because Norplant is only one MCQ you can get on Norplant, that which contraception has the lowest uh, failure rate, or we can say which has the highest efficacy. Which contraception has the highest efficacy? Answer is implants. Within the implants, what implant is has the highest efficacy? It is Nexplanon. Nexplanon or the Implanon has the highest efficacy, and these are not available under the Government of India program. Under the Government of India free program, we only have these contraceptives which are available, plus the iPill and the Easy Pill. Okay, so based on this MCQ, if you just know which IUD is available, it is copper T 375 as the best answer. Let's go to the next one. OC pill, for this is a very frequently asked MCQ beta. This is a 5 by 10 star MCQ topic. OCP for a non-breastfeeding postpartum female can be recommended after how many days? 3 weeks, 6 weeks, 3 months, or 6 months? So what do you think? What do you think? 3 weeks, 6 weeks, 3 months. So I am showing you a simple, very simple algorithm for initiation of postpartum family planning methods. Initiation of postpartum family planning methods, when to start. So please note, first is in case of breastfeeding female. In case of breastfeeding female, we can give them intrauterine device. We can also give them OC pills. Intrauterine device can be started after 6 weeks. OC pills can be started after 6 months. Very important. In breastfeeding females, can you see that the injection DMPA can be started after 6 weeks? OC pill IUDs can be started after 6 weeks, and OC pills can only be started after 6 months. Can you see this? After 6 months, OC pills can be started. So we can give IUDs, we can give DMPA, we can give OC pills. These all in breastfeeding females can be started at that much time. So DMPA, we did not write DMPA, DMPA or the Antra can also be started at after 6 weeks. Now point comes in non-breastfeeding females. This is the MCQ. In non-breastfeeding or non-lactating females, what to start, when to start. In females beta who are non-breastfeeding, the oral contraceptive pills can be started at what time? They can be started at 3 weeks. When can we start injection DMPA? DMPA can be started just at the time of delivery. Are you getting this? This is important difference. Injection DMPA in breastfeeding females is started after 6 weeks. In non-breastfeeding females, OC pills and DMPA, dono ka time is going to change. IUD time is going to remain same. So remember, IUD will remain same 6 weeks. Then is OC pills. They can be started after 3 months also. And DMPA can be given even after delivery as soon as possible. In non-breastfeeding females. Are we clear on this? This could be your potential MCQ. This could be your prospective MCQs. When to start IUD? Everybody's already asked this. IUD can be started after 6 weeks. But now the MCQ can be asked on OC pills in breastfeeding, non-breastfeeding, DMPA in breastfeeding and non-breastfeeding. Next is last point. When can you give Centchroman or Chaya? Chaya tablets or the Centchroman tablets? When do you think? When do you think we can give Chaya tablets or the Centchroman? Centchroman tablet, can you see, surprisingly can be started any time after delivery. I am not saying this. This is by the Ministry of Health and Family Welfare, Manual for IUCD, training for medical doctors. Centchroman can be started any time after delivery. Why any time after delivery? Because the mode of action of the Centchroman is selective estrogen receptor modulator. They are non-hormonal. They are non-hormonal contraceptives. Where can we get this slide for postpartum family planning? Beta, it's already there in Telegram group. Everything is there in Telegram group. Telegram group. Coming to the coming to the previous MCQ, OC pills for non-breastfeeding females postpartum. Postpartum non-breastfeeding female can be recommended after 3 months. Can you see here? It can be recommended after 3 weeks. Sorry, not months. It is 3 weeks. It is not 3 months. This is by mistake. 3 weeks. So answer is 3 weeks, not 3 months. Answer is 3 weeks. So OC pills in non-breastfeeding, it is 3 weeks. 3 weeks. 3 weeks, not 3 months. By mistake, I told it as 3 months. It is 3 weeks. So OC pills can be started after 3 weeks. As you can see already in the screen, we can start OC pills after 3 weeks, not 3 months. It is 3 weeks. Okay. Yes, Niyati, it is 3 months or 3 weeks. Thanks for correction. It is 3 weeks. Last topic in the demographic question, high birth rate with declining death rate is seen in what stage? High birth rate with declining death rate is seen in stage 1, 2, 3, 4. What do you want to say? High birth rate with decrease in death rate is a feature of stage 2. High birth rate with decrease in death rate is a feature of stage 2. Very quickly, you already know this. This is a super duper easy MCQ and it is a frequently asked topic. It is a 5 by 5 star MCQ topic. It is a 5 by 5 star MCQ topic. Phase 1, 2, 3, 4, 5. High stationary, early expanding, late expanding, low stationary and declining. In the first phase, in the high stationary phase, beta, there is a summary table of the biostat, of the demography. Summary table for the demography. So high stationary is high birth rate, high death rate. Early expanding is high birth rate with death rate starts decreasing. Stage 3 is birth rate for the first time starts decreasing. Very important, frequently asked MCQ. Birth rate will start decreasing in stage 1, 2, 3, 4 or 5. It is in stage 3. Death rate will be slow decline. Stage 4 is slow declining birth rate, death rate, and phase 5 very low or stable death rate. This has been asked so many times. Stable death rate with still a declining birth rate, or the first time the birth rate may be lower than the death rate. Birth rate lower than the death rate is a feature of stage 5. So you can have stage 1, 2, 3, 4, 5. Explosive growths are seen in every word in this slide is important. Explosive growth is a feature of stage 2. Demographic gap starts increasing. What is demographic gap? Difference between the birth rate and death rate. The demographic gap starts increasing in stage 2. Maximum DG towards the late part of stage 2, high fertility rates could be there. In stage 3, the population will increase, but mind the language, the rate of increase of population in stage 3 is lower than the rate of increase of population in stage 2. So growth rate is lower than the stage 2. Demographic gap starts decreasing. Gift or bonus is seen. It has been asked multiple times in your exam. This is a frequently asked question. Dependency rate is lower, ratio is lower. Again, a frequently asked MCQ in your exam. So what is stage 1, 2, 3, 4, 5? Very important. High stationary, early expanding, late expanding, low stationary and declining. Demographic gift is seen in stage 3. Demographic liability is seen in what stage? What do you want to say? Write in the chat box. Demographic liability is seen in, yes, stage 5. Demographic liabilities are seen in stage 5. So what is the best answer over here? I think it's a super duper easy MCQ. Answer is correct. Stage 2. This comes the most controversial, big headache for me also. This is one of the most controversial questions. Leading cause of under 5 mortality. Leading cause of under 5 mortality. What do you think is the leading cause for under 5 mortality? Beta, leading cause for under 5 mortality, pneumonia, septicemia, hypoxia or prematurity. Under 5 mortality, if they ask you under 5 mortality. So 0 to 5 years cases, what is the leading cause of death? Leading cause of death. Nothing mentioned. Beta, if nothing is mentioned, you have to follow SRS data. If nothing is mentioned, follow the SRS data. Okay. There are actually two types of data sources. I'll tell you how the confusion started. The confusion started from these two sources. The confusion started from the report on medical certification. The point is medical certification cause of death 2020. And there was another question, there was another report which was causes of death statistics 2017-19. This was again by Registrar General, Government of India. This is what is the SRS data. And this is what is called as the MCCD data by the again by the registrar. They are both from the same company. You see the same logo? Can you see the same logo? At least you can see the same logo. They are by the same company and by the same Government of India. You can see the emblem also of the government. So these two reports are there, but this report which is there on the right side, that is a medical certification cause of death. It is more valid. It is more valid for adult population or overall population or adult population. Why? Because these are the people who will take the medical certificate reports. Whereas generally talking, SRS data is for any cause of death. Beta, as far as the SRS data is concerned, number of deaths in age group 0 to 1 year, the best answer is always low birth weight and prematurity. That is accounting to 36% of all the deaths. Low birth weight and prematurity. 0 to 1 year. Death says low birth weight, prematurity. This is as per the SRS data. SRS data using a rhyme technique. This could also be your prospective MCQ. What is rhyme? Rhyme stands for representative, resampled, routine household interview for mortality with medical evaluation method. This is the technique that we use in SRS to find out the cause of death. It is called as rhyme, resampled, restructured, routine, representative household interview for mortality with medical evaluation method. So this is what is the most common cause. What is the most common cause? It is low birth weight, prematurity. Now, in case the MCQ specifically says MCCD cause, medical certificate cause of death, in these cases, beta, you need to mark hypoxia as the most common cause, hypoxia or birth asphyxia as the most common cause. But if nothing is mentioned, you have to follow the SRS data. So just to summarize, I don't want to create a lot of confusion. I just want you to remember that what is the most common cause of deaths. Most common cause of death for infant mortality, it is low birth weight and prematurity. Neonatal mortality is low birth weight and prematurity. Early neonatal mortality rate is also prematurity along with low birth weight. Under 5 mortality rate is also prematurity and low birth weight. Now comes what is child death rate. Beta, if you have attended my lectures, you already know what is a child death rate. It is death of children age 1 to 4 years. Death of children age 1 to 4 years divided by total children. Total children of same age. Total children of same age group. So deaths of children age 1 to 4 years. That means in under 5 age group, after infants, what is the cause of death? Now the answer is usually infections, prematurity and infections, malnutrition and so on. So now the answer would be malnutrition, and it could also be septicemia, or we can have other infections. Are we okay? So for any question you are supposed to mark for any MCQ, please mark this as the best answer. These are the single best answer. Now, in case there is a special MCQ, where the question only says medical certificate cause of death. Now, in MCCD cause of death, you have to write hypoxia. Or birth asphyxia as the best answer. So that is your best answer. Then child death rate, most common cause is septicemia. Which is more common, pneumonias or diarrhea as a cause of death? Please note, children get diarrhea more, but children die because of pneumonia more. Which is more fatal, which is more killing? Pneumonia is common sense, more killing. Pneumonia is common sense, more fatal. Are we okay with this? So what is this? Child death rate, what is the most common cause? It is malnutrition and septicemia. If you get single best answer, you should be marking malnutrition, but it's something like malnutrition will cause septicemia, na? ऐसे तो what causes malnutrition? Poverty causes malnutrition, गरीबी causes malnutrition, then the root cause of everything in the world is poverty. We can't do that, right? So malnutrition is actually a social problem which leads to septicemia. So if you get both the answers, malnutrition rules. But if malnutrition is not there in the answer, in the option, then you go with septicemia. What is the single best answer in any type of MCQ? It has to be low birth weight prematurity. PSM will say that, pediatrics will say that, gynae will say that, everybody, medicine will say that, everybody is going to say the single best answer is low birth weight prematurity. And common sense also says that low birth weight prematurity is the most common reason for children deaths age 0 to 1 year, age 0 to 7 years, 7 days, 0 to 28 days, whatever it is. So I just want to solve this controversy. Beta, please note, summary of the game is this is what is the summary of the game. If you get any MCQ, you have to mark low birth weight prematurity as always the best answer. Okay, in certain cases septicemia can be answered, but if somebody says medical certificate cause of death, then you have to follow this special MCQs. Otherwise, take it up easy and take it simple. What is the best answer for under 5 mortality? It is low birth weight and prematurity is the single best answer over here. Low birth weight prematurity is the single best answer for under 5 mortalities in India. That is the best answer for us to follow. Next is, which of the following is not correct for perinatal mortality rate? Which of the following is not correct for perinatal mortality rate? What is a perinatal mortality rate? Options are, it is a good indicator for availability of health facility, includes stillbirths and late neonatal deaths. Denominator is total births, include fetal deaths after 28 weeks. Please note, what is perinatal mortality rate? Perinatal, PNMR. Perinatal mortality rate. Perinatal mortality rate is given by the formula. It includes the stillbirth rate plus the early neonatal mortality rate. Please note, it does not include the late neonatal deaths. It is stillbirth rates plus the early neonatal mortality rate divided by the live births plus the stillbirths divided by the total births divided by the total birth. So I will show you a screenshot from the Park 27th edition. 27th edition. What is perinatal mortality rate? Beta, perinatal mortality rate is, if you just look at this, perinatal mortality rate is late fetal deaths, that is 28 weeks of gestation or more, plus early neonatal deaths divided by late live births and late fetal deaths. That is 28 weeks of gestation or more. This solves 2 MCQs over here. That's many times students have asked me, what is a stillbirth? Stillbirth is not after 22 weeks. Stillbirth is death of a fetus which is more than 28 weeks of gestation. This is a huge controversy in the country which is going on. It is not 22 weeks, it is 28 weeks. So that is the perinatal mortality rate for you guys. So please remember, what do you mean by the perinatal mortality rate? Perinatal mortality rate includes the stillbirth rate. What is the stillbirth rate? Late fetal deaths, that is more than 28 weeks, plus early neonatal mortality rate. What do you mean by early neonatal? That is 0 to 7 days. 0 to 7 days divided by the stillbirths plus the live births, that is perinatal mortality rate. That is perinatal mortality rate. So I hope you should be clear on this. This is a small chart. You can just take a screenshot of this. These are all the important formulas, from mother and child health that can be asked to you in your exam. Take a screenshot of this, beta. What do you mean by infant mortality rate? So take a screenshot of this. What do you mean by infant mortality rate, neonatal mortality rate, child death rate, maternal mortality ratio, and a stillbirth rate? This is a whole menu of rates: infant mortality rate, neonatal mortality rate, stillbirth rate, child death rate, child mortality rate, maternal mortality ratio. What are the different formulas? So please make sure that you do your formulas correctly. This is a prospective MCQ. It can be asked in your exam. Child mortality rate, everybody knows. Neonatal mortality rate, everybody knows. Number of stillbirths in the area divided by total number of births in the area is stillbirth rate. Okay. Many of you asked me on Telegram group yesterday night, like, what are the latest India's indicators? So country India, what are the indicators? Birth rate for India is 19.5. Death rate is 6.0. You can take a screenshot of this also. It is important. It is a 5-star MCQ topic, 7 by 10-star MCQ topic. What are the latest indicators? This can be asked in your exam. Birth rate is 19.5. Death rate is 6.0. Please remember that the infant mortality rate is 28. Neonatal mortality rate is 20. Maternal mortality ratio is 97. This can be asked in your exam, what is maternal mortality rate? This is what is a prospective MCQ. This can be asked in your exam, what is lifetime maternal risk? Very important MCQs. It can be asked prospective MCQs beta. Sex ratio, I think everybody knows it is 1020. Next in line, come to the other side. TB incidence can be asked in your exam. This is a prospective MCQ. Leprosy we have already done. It is 0.45. Total fertility rate can be asked in your exam because it was the latest data given by the National Family Health Survey. So whatever I am highlighting can be asked in your exam. These are some of the important numbers. Okay. That's all about the demographic rates. Coming over to the biomedical waste management, a lot of questions and doubts are coming from biomedical waste management. Poonam, paclitaxel vial and broken paclitaxel vial, way to discard. So don't worry, that's super easy. Anyways, coming to your biomedical waste management, personal protective equipment as face shields are discarded in. Beta, you already know that what are the elements of the personal protective equipment. Personal protective equipment, we have these 6 elements. We have the head cover, face shield, face mask, gloves, apron, and shoe cover. So it's not show cover, it is a shoe cover. So head cover goes into which category? Yellow category. Face shield goes into the red category. Face mask goes to the yellow category. Gloves go to the red category. Apron goes to the, apron could be synthetic or it could be synthetic or plastic, or it could also be semi-synthetic or linen. If it is synthetic beta, if the apron is synthetic, it goes to the red category, whereas if it is semi-synthetic or linen, it will go to the yellow category. Shoe covers will always go to the yellow category. Shoe covers will always go to the yellow category. So that is about the COVID-19 biomedical waste management for the personal protective equipment, how to discard. You should be knowing these are very frequently asked MCQs, which goes into the yellow category, which goes to the red category, which goes to the blue category, and what goes to the white category. Yellow category is all body parts. Dressing material, intrauterine device. So take a note on this, intrauterine devices. All body fluids, which includes sputum, urine, and all that. X-ray fluids, washing chemicals, lab waste, unopened vaccine vials, blood bags, vacuolators with blood. They all go to the yellow category. You should also note that drugs which are expired or cytotoxic drugs, they go to the yellow category. Now the question which was asked to me right now by Poonam was, what about the paclitaxel, which is a cytotoxic drugs? I hope everybody knows what are cytotoxic drugs. These are the anti-cancer drugs. So any material which is used for these anti-cancer drugs or any equipment which is used for the cytotoxic drugs or the cytotoxic drugs themselves or their any vials or any material which is there with the cytotoxic drugs is all disposed of in the yellow category. What happens is, look at the screen, what happens is that there is a yellow category. The yellow category contains, like this, the bag. You must have seen a biohazard symbol sometime. This is a biohazard symbol. So everything is put into the yellow category. Now, in case there is cytotoxic drugs or their related materials, now this goes to a special bag beta with a special symbol C. So anything, vial of the paclitaxel or the paclitaxel itself or the IV set which is used for use of the anti-cancer drugs, everything goes into the cytotoxic category. Cytotoxic category is a yellow category. Am I clear on this? You don't have to bang your head that blue, maybe for the vial. Broken vial, unbroken vial, scratch vial, cut vial. Don't get into all this. That's overthinking. Come down, relax. Any cytotoxic drugs or their material associated will blankly go into the yellow category. Trust me, whenever there is exception, I will be the first person to tell you the exception. Otherwise, trust me, everything is super duper easy. All yellow category is biohazard except the cytotoxic and the related material, they all go into the yellow category. Shivam asked me about the pacemakers. Pacemaker contain battery. Battery is not a biomedical waste. In that sense, Shivam, next MCQ you will ask me is, what about the cochlear implant? Cochlear implant contain battery. Cochlear implant is not a biomedical waste. Pacemaker is not a biomedical waste. They are packed, given back to the manufacturer. Okay, so please remember, these are very simple things. Do not overthink. This is one chart for you. You can remember this and do for your MCQ exams. Can I get some water? Yeah, hot water. Thank you. Red color category, blue category, and white category. What do you mean by red category? Red category, what are we going to throw in the dispose of in the red category? In the red category, we are supposed to dispose of anything which is rubber, anything which is plastic, and anything which is tube. So Ryle's tube, nasogastric tube, catheters, urine bags, IV drip sets, empty vacutainers, syringes, gloves, everything goes into the red category. Don't overthink that maybe gloves which are stained with HIV blood, they will go into the yellow category. No, all gloves, any type of gloves, nitrile gloves, vinyl gloves, every glove will go into the red category. All gloves, it could be vinyl gloves, it could be nitrile gloves, it could be rubber gloves, it could be non-rubber gloves, whatever material you can fancy think of in the gloves go to the red category. Syringes, yes, there is one exception. All syringes will go to the red category except syringes with fixed needles. Can you read this? Syringes with fixed needles will go into the, thank you. Syringes with the fixed needle will go into the, syringes with fixed needle will go into the white category. All syringes will be disposed of in the red category except syringes with the fixed needle which will go into the white category. Coming over to the blue category. Please note that any unused vials, broken glass, unused vials, orthopedic implants, they are all in the blue category. Example for this would be slides, blood slides, any slides, malaria slides, any slides, vaccine vials which are empty and broken, Point to be noted, empty. Please note that filled up vaccine vials, I've already discussed with you, unopened vaccine vials, these are in yellow category. So red means rubber is tube, rubber with blood, without blood, any rubber has to go into the red category. Another exception, vacutainers, vacutainers empty go into the red category. Vacutainers with blood go into the yellow category. Vacutainers with blood go into the yellow category. Empty vacutainers go into the red category. Empty vacutainer is red category. Okay. So that's all. Any other doubts, please shoot. Please put your questions. So please tell about management of these. Management beta, it's all going into the, you have the yellow category, red category, blue category, white category. Yellow category is mostly incinerated. Except some of the yellow categories where the pharmaceutical drugs are there, drugs can be returned back to the manufacturer, but mostly it has to be incinerated. I would also like to tell you what probably you were asking me was the yellow category F, yellow G, and yellow H. These are three categories. Yellow is further divided into A, B, C, D, E, F, G, H. I hope you remember. Yellow F, G, H, the last three. F stands for the fluid category beta. G stands for gadda or the gown or the linen, all the hospital linen. H stands for the hazardous or the laboratory waste. So these are the three categories which are pre-treated. Always they have to be pre-treated before disposal. This can be asked in your exam. The red category, the blue category, and the white category, they all have to be pre-treated if infectious. Of course, anything which is non-infectious does not need to be pre-treated. But if they are infectious, you should blood slides. If it was a new slide, why would you pre-treat it? But if the blood slide was there with blood, you discard the blood in the yellow category, and the blood slide should be done with chemical treatment. Chemical treatment should be done for the blood slide. Okay. Open vaccine vial with the residual vaccine. Beta, it's open vaccine vial with the residual vaccine. Anywhere if you have a residual vaccine, that goes into the yellow category. Okay. So I think that's all about the biomedical waste. Next is coming over to sociology, right way of doing things in the societies. So what do you think? Coming back to the MCQ, protective equipment as face shields are disposed of in what category? They are disposed of in the red category. Coming to the next MCQ, right way of doing the things in the society is, what do you think? Folkways, mores, culture or tradition? This is again from a flashcard number 1057, which was shared on the Instagram, on Telegram, everywhere. You should note what are the definitions. Very frequently people ask you, what is crowd, what is mob, what is herd? What is culture, acculturation, custom, folkways and more? What is folkways? Folkways you can see is right ways of doing the things. What is custom? Custom is established pattern of behavior which is normal for a society. But the right way of doing things is folkways. What are mores? They are stringent customs. Okay. What is acculturation? That is mixing of two cultures. Culture is nothing but a learned behavior. People are born accultured and then they learn their culture. So people who are born in South India, they may have a different culture. People who are born in Telangana will be different culture compared to Tamil Nadu, and people in Delhi will have a different culture compared to Punjab. So different cultural is a learned behavior. We are usually born with the same culture, that everybody is humans. Right way of doing things is what is folkways, stringent customs are mores. What is attitude? Attitude is the way we behave. Okay. Attitude is the way we react. I have remembered this as reaction. Attitude is my reaction. Now my reaction is based on my knowledge. It is based on my emotion and tendency for action. Now this reaction could also be motivated. That is what is habit. What is habit and what is attitude? Attitude is knowledge based. It is permanent and not influenced by motivation. This can be your MCQ. Attitude, his attitude is like this. He has a different attitude. He is always angry. That's an attitude. It's a permanent thing and it is not influenced by motivation. You can't say that, sir, bhaiya, you should feel happy sometime. You can't motivate that. You can't change that attitude. What is habit or practice? Practice is established way of doing things and that you learn by doing things again. It is influenced by motivation. So just remember what is attitude and what is habit. Habit is motivated, induced or influenced, and attitude is motivation, not influence. Okay. I think this is the third time I am seeing this request regarding impairment, disability, handicap. Impairment. What is impairment? Impairment is anatomical loss, beta. Loss of anatomical organ. Bande ke ungli kat gaya, that is impairment. Anatomical loss or physiological function, that is impairment. Now because of the impairment, agar wo patient becomes disabled to do some work or activity, that is called as disability. Patient ka ungli kata, that is impairment, but because uska ungli kata, he could not write and you are able to write, that is disability. He was disabled to write, you are able to write. Next is because of that person was not able to write, you are able to write. There may be handicap. Handicap kya hota hai? It is loss of social role. Loss of social role or occupation or job. Because that person lost the fingers, impairment, he was not able to write, you are able to write, you became very good doctor, he did not become a doctor because he wanted to become a doctor, but he could not because he could not write. Why could not he write? Because there was impairment. Impairment will cause disability, disability will cause a social loss, that is handicap. Handicap is a social phenomena. Impairment is a clinical phenomena. Whereas in public health, we talk about disability. Disabilities can be measured using DALY. We can also measure disability rates using Hale or Qualley. So best measure for disability is DALY. Now you understand what is DALY. DALY is the measure of disability. DALY is the measure of seriousness. DALY is the measure of impact of a disease on a person. वो कितना प्रॉब्लम है, उंगली का नाखून कटना is also, nail of a finger is also impairment. If somebody loses nail, that is also impairment. His nail is impaired. Now because of that impairment, how much is the disability that is going to be graded? So person loses finger, one arm, heart, full body, what is that? That is all is DALY. Okay, so that's about DALY. Let us come to the last portion, last chapter that is biostats. Last chapter that is biostats, and we are finishing it off. I think we have only very few students left out now. So 200 individuals were tested positive for COVID-19 using rapid antigen test. Using RT-PCR as gold standard, only 150 of those were found to be diseased. Which of the following is correct? So this question is saying that out of total people, 200 people were tested positive. So the test positive was there in 200 people. Okay. Now using RT-PCR as a gold standard, 150 were found to be diseased. So how many were diseased out of these 200? It was found that 150 were diseased. So how many will be non-disease? But they were tested positive. That is 50. Okay. Which of the following is correct? PPV is 75, sensitivity is 25, false positive is 50, specificity is 75. Very simple question. Beta, what is sensitivity? What is specificity? What is PPV, NPV? If you make a box like this, you should always remember this is true positive, this is true negative, this is false positive, this is false negative. So the number of people who are true positive out of the total disease, true positive divided by true positive plus false negative. This is what is true positive divided by total D plus. This is what is D plus, this is D minus, this is test positive, this is test minus. So what is this called as? This is called as sensitivity. This is called as sensitivity. So how will you remember it? True positive by D plus is sensitivity. On the other hand, if you talk about true negatives divided by true negative divided by D minus, this is what is called as specificity. What is the formula for specificity? It is true positive divided by true negative divided by true negative plus false positive. That is specificity. On the other hand, if you look at true positive divided by the total tested positive, that is true positive divided by tested positive. This is called as positive predictive value. This is called as positive predictive value. PPV is given by true positive divided by true positive plus false positive. On the other hand, if you talk about this side, true negative divided by total tested negative, that is true negatives divided by true negative plus false negative. What is this called as? Negative predictive value. This is called as negative predictive value. So that's the only MCQ you get in your exam. So I'll repeat again. What is this over this? This is called as PPV. What is this over this? This is called as sensitivity. On the other hand, talking about true negatives, true negative divided by the healthy, this is called as specificity. And on the other hand, true negative divided by the tested negative, this is called as negative predictive value. So these are the only 4 things that you need to do for your exam. Please note that what is the probability of having tested positive out of disease is called as sensitivity. Out of healthy, if you talk about tested negative, that is specificity. Out of tested positive, how many are diseased? That is PPV. That is what this MCQ was. Last is out of tested negative. How many people are healthy? This is negative predictive value. So please remember, if the question is out of disease, answer is only one, that is sensitivity. Out of healthy, answer is only one, that is specificity. Out of tested positive, answer is only one, that is PPV, and tested negative, answer is only one, that is negative predictive value. So what is the best answer over here to this question? This question is saying 150 out of 200 are tested positive. It is saying that 150 out of 200 are tested positive. What is the best answer? It is PPV is 75%. That's the best answer over here in this question. Coming to the next MCQ, a research was conducted to assess 2 drugs to lower cholesterol. A research trial was done and the newer drug showed good results as cholesterol lowering agent with p-value of 0.08. Which of the following is correct interpretation? A research was conducted to assess two drugs for lowering cholesterol. Two drugs were there. Two drugs were assessed. The research trial was done and the newer drug showed good results as cholesterol lowering agent with a p-value of 0.08. Okay, so now the question is that the newer drug showed a better result with p-value 0. Which of the following is correct interpretation? Newer drug has negative association. Newer drug is 0.08 times more potent. Newer drug does not show statistical superiority, or the results are inconclusive or non-conclusive. What do you think is the best answer? So what do you think is the best answer over here? If you look at this, you already know this normal distribution curve. You already know the normal distribution curve. Beta, how much people will be between plus minus 1 SD? Between plus minus 1 SD, it is 68% of the population. Between plus minus 2 SD, we have 95% of the population. Between plus minus 3 SD, we have 99% of the population. How much is the p-value at this minus 2 SD? At this minus 2 SD, the p-value is 0.05. So very simple to remember now. Very simple to remember now that p-value, it could be less than 0.05 or it could be more than 0.05. If the p-value is less than 0.05, so where does this p-value lie, beta? In this normal distribution curve. If the p-value is less than 0.05, this is what is p-value 0.05, okay? This p-value is 1. So as you go outside, the p-values will increase or decrease, they decrease. So if the p-value is less than 0.05, that means they lie within plus minus 2 SD or outside plus minus 2 SD. If it is, the p-value is less than 0.05. If the p-value is less than 0.05, they will lie outside plus minus 2 standard deviation, and outside plus minus 2 standard deviation, this is what is the significant zone, within which is the normal zone, because plus minus 2 SD is the normal zone. So this is a non-significant zone and outside is the significant zone. So anyways, if you remember, absolutely correct, Gurdeep Saini, you have told it, yeah, it is null hypothesis will be accepted. So p-value, if it is less than 0.05, if the p-value is less than 0.05, if the p-value is less than 0.05, that means it is outside the normal zone. The effect is found, the p-value is significant, null hypothesis will be rejected. On the other hand, if the p-value is more than 0.05, that means they are within the normal zone. More than 0.05, that means within the normal zone. No effect is observed, p-value is non-significant, and null hypothesis is accepted. You have to remember this for your exam. This is what is the crux of the total biostats for your exam. This is the total crux of biostats for your exam. Coming to the next MCQ, just two more MCQs on biostats. So I think, what is the answer to this question? A research was conducted to assess two drugs. The research trial was done. Newer drug showed p-value of 0.08. 0.08. That means what? Significant. 0.08. That means significant or non-significant? It is a non-significant. It is a non-significant p-value. So the newer drug does not show statistical superiority is the best answer over here. Of course, newer drug may be more effective, but is it statistically significantly effective? No, it is not statistically significantly effective. Let us go to the next MCQ, the test of significance to compare the blood glucose level in three groups receiving Ayurvedic medicine, homeopathic medicine, and allopathic medicine were taken. So the groups were to compare the blood glucose level in three groups. A study was done over 2 years along with diet modification and physical exercise. What is the test of significance? What is the test of significance? So you have three groups. So you were checking for the blood glucose level. Beta, what is the test of significance to be used here? Blood glucose level, what do you think is quantitative or qualitative? It is a quantitative parameter. It is not about a diabetic or non-diabetic. It is about the quantitative parameter. These are blood glucose level. So the test of significance, this is a simple flashcard for you. Test of significance can be of two types, parametric or non-parametric test. The parametric test, these are for quantitative data, whereas for qualitative data we have is the non-parametric test. Parametric test could be done in single group, two groups, or three or more groups. Paired t-test, unpaired, or ANOVA. Non-parametric test, we can have McNemer test, chi-square test, or Kruskal-Wallis test. We can have McNemer test, chi-square test, or Kruskal-Wallis test. So what is the non-parametric test for three groups? It is Kruskal-Wallis. If you can remember for your exam Kruskal-Wallis, it's fine. Otherwise, you can just forget. Just remember, chi-square can be used actually anywhere in the non-parametric side. In the parametric side, we can have paired t-test, unpaired t-test, or we can have is the ANOVA test. So as you can see already in the MCQ, what did we see? We are talking about the quantitative test, and how many groups are there? There are three groups. What is the best answer over here? The best answer is ANOVA test. The best answer over here is ANOVA test. Absolutely correct. It is ANOVA test. It is ANOVA test. Okay. Coming to the next MCQ. In a town, 500 school-going children were selected for anemia survey. In a town, 500 school-going children were selected for anemia survey. The school had boy to girl enrollment ratio of 60 to 40. Hence 300 boys and 200 girls were selected for this study. This is type of what? Random sampling, systematic sampling, cluster sampling, or population proportionate to size sampling. So what do you think? In a town, 500 children were selected for anemia survey. The school had boys to girl enrollment ratio of 300 boys, like 60 to 40. So out of 500, I think they had taken 300 and 200, which is like 60% and 40%. So what type of sampling is this? Random sampling, systematic sampling, cluster sampling, or population proportionate to size sampling? Beta, this is an example of none of the above actually. I'll come to the answer, but this is an example, what you guys might be knowing, this is an example of stratified sampling. The stratified sampling is based on a certain separate characteristic. You wanted to enroll children. Children are divided into boys and girls. So now you will take up boys, some boys and some girls. Now the stratified sampling could be simple stratified sampling based on like how many groups? Two groups. So I'll take 50% and 50%. Out of 500, let us say I was taking 500 children. So there are boys and there are girls. I will not say 60 and 40. I'll not see this. I'll just see how many groups are there. Boys and girls. Two groups. So I'll take 50% out of this, 50% out of this. That is 250 and 250. But this is called as simple stratified sampling. Okay. This is called as simple stratified sampling. There is another point. The point is that out of 500, in reality, 60% were boys. So I should be taking 60% of the boys now. That is 60% of 5. That is 300 and 200. This is what is called as population proportionate to size. Population proportionate to size. PPS sampling. Population proportionate to size sampling, PPS sampling. Now this PPS sampling is a type of, stratified sampling. It is a type of stratified sampling. This is very important for your MCQ exam. This could be your prospective MCQ. Just a very quick review about the last point about other types of sampling methods. You can take a random sampling method where you can just take any random number 1, 5, 10, 11, 12. You can take random numbers. Or you can take every third child, every third person, 1, then every third, then you every third, then every third, and you pick these sample. So this is called as systematic sampling. This is called as systematic sampling. So we can have a random sampling where you just take any random number. You can have systematic sample. What is this cluster sampling? Cluster sampling is cluster sampling. Cluster sampling is in clusters. So there are usually naturally occurring groups. So this also has been MCQs. Naturally occurring groups are called as clusters, naturally occurring groups. Naturally occurring groups are taken. They are randomly chosen. Naturally occurring groups will be taken. It is usually for large homogeneous sample, homogeneous population. And what is the use of cluster sampling? The use of cluster sampling has been asked million of times in your exam. It is used to find out what is it used to conduct survey. No, it is not done to conduct survey. It is usually done to evaluate a health program. Cluster sampling is usually done to evaluate health program. Last point, what are the examples of cluster sampling? The examples of cluster sampling in universal immunization program. In universal immunization program, we use cluster sampling method where we take 30 clusters in a district, in an area. We take 30 clusters in the area. Out of these 30 clusters, we take 7 children per cluster. So 30 clusters, each with 7 children, 210 children are assessed in the universal immunization program. Another MCQ, another example that you can remember for cluster sampling could be the NIDDCP. Under the National Iodine Deficiency Disorder Control Program, beta, we take 30 clusters. Out of these 30 clusters, we take 90 children. 90 children 6 to 14 years of age are taken. 6 to 14 years age, 90 children are taken, which are taken from equal gender, like both boys and girls are taken gender wise, and based on school enrollment ratio. It is based on the school enrollment ratio in the area. 90 children are selected. So total in NIDDCP, how many children are selected? 2,700 children are selected per area to find out the NIDDCP indicators like the goiter rate, the urinary iodine excretion rates, and the iodine in household salts. Okay. Last 2-3 points. A few points about the air quality parameters. Air quality parameters, beta. It includes 8 air pollutants. We did not do the previous answer. Did we do the previous answer? So in this town, 500 children were selected for the anemia survey. The school had boy to girl enrollment ratio of 60:40, 300 boys, 200 girls. What is the best answer? The best answer over here is population proportionate to size. This is example of stratified sampling. What is the sampling used to study dietary habits with different religions in the population? So with different religions are there, you stratify them into different religions, and each religion should have equal proportionate. Best answer would be stratified. Of course, out of stratified, you can always better to do a population proportionate to size. For example, what you are saying, you will select 1,000 people in the area, and there are Hindus, there are Christian, there are Sikh, and maybe there are Buddhist and Jain. Okay, just assume. So let us say I take stratified sampling. So how many groups I see? 5 groups. So ideally I should be taking 200, 200, 200, 200 and 200 population stratified sampling. But what if I find out in my area Hindus were 80% of the population, 15% were Christian, 4% were Sikh, 0.5% were Buddhist, and 0.5% were Jaini, and there were some other. So I should be taken population proportionate to size, that is out of 1,000, 800 should be Hindus, 150 should be Christian, 40 should be Sikh, and so on. Are you getting this? How to make the sample? This is also a stratified sampling. Shivam Sharma, but they are naturally occurring. Yes, cluster sampling is naturally occurring clusters. Okay, cluster sampling is within the naturally occurring cluster. This has been your previously NEET exam question, that are they naturally occurring or do we make these clusters? Please note they are naturally occurring clusters. So just last point to cover off the story from air quality. Air quality, please note how many pollutants we take. We take 8 air pollutants. It takes into account particulate matter and particulate matter 10 and particulate matter 2.5 mm, two particulate matters, ozone, sulfur dioxide, nitrogen dioxide, carbon monoxide, lead and ammonia gases. Lead is a marker for pollution, occupational pollution. Sulfur dioxide is for industrial air pollution. And based on this, we divide the air quality. Less than 50 means super good. Less than 100 is okay. More than 300 is poor. More than 400 is severe. So remember, these are the air quality parameters. So you see that air quality parameters, less than 50 is good. 50 to 100 is satisfactory, 200 more is poor, 300 is very poor, and 400 is severe air quality. So these are some of the MCQs, like you will get, like which are the louse-borne, flea-borne, tick-borne. You can take a screenshot of this, and these are also available from my website mukhmohit.com or psmsimplified.com. You can check this out. Louse-borne, flea-borne, tick-borne illnesses. Which of the following are louse-borne, flea-borne? A collection of all the formulas. It's also there in many PDFs. These are all the formulas which may be asked in your exam. What is risk ratio, what is odds ratio, what is attributable risk, absolute risk reduction, sensitivity, specificity, the formulas you have already done, coefficient of variation, biostats formulas, and then you should also note what is GFR, TFR, GRR, NRR, very frequently asked in your exam. What is Pearl's index, dependency ratio, net protein utilization, and corrected effective temperature. So with that, that's all for the day. Which step have you reached today? One was procrastination. I won't do it, I can't do it, I want to do it, how do I do it, I'll try to do it. And last is, yes, I did it. So you have to reach at that point that yes, you are able to do it. And with that, I'd like to thank you so much for joining in the, I think it's been a 3.5 hour, 3 hours plus 4 hour, close to 4 hour session. So I'm also starting, everybody in my house is starting to stare me like, are you going to hit the students so hard today with PSM? So thank you so much for joining in the session today. Beta, the resources that you're going to use. Some students, can the PSM booster be facilitated? Last time, apology for interacting and interrupting flow. So yes, PSM booster is about PSM booster. It is kind of okay, but it contains mostly the recent updates, and it has only 20 points in PSM. It has only 20 points in PSM. It is not, I would not say that it is, you can say it is, I won't say that you can substitute it with anything. The best source that you would like to do right now is PSM revision from the Marrow revision modules. Of course, you just have very few days, hours left now. Marrow revision modules, or you can take the One Touch PSM book, or you can watch all this YouTube session. So I have tried to cover almost 80% of community medicine in last 3.5 to 4 hours. The one resource that you can add extra is the PSM Simplified website. In this website, beta, if you go to /updates, you will find lot of PDFs. In the PDF, you search for NEET entrance exam topics, high yield topics. You will see all the topics, all the checklist is there. Do tuck, 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 tuck. I have done all this. Any doubts you have, you're most welcome to shoot it on the Telegram group. Any doubt, you're more than welcome to put it on this Telegram group. I would request everybody to join the Telegram group. And on Instagram, this is my handle, and Instagram is for flashcard recent updates. I cannot answer on Instagram. It is very difficult to answer personal messages. I cannot do that. Yes, doubts, controversies, and all your questions, please post it on the Telegram group. Please post it on the Telegram group. Okay. So with that, I'd like to thank you so much for watching this whole session, and I hope we could justify your 3-4 hours and we could just cover up almost 80%, 85% of community medicine. Thank you so much. Have a good day ahead and all the very best. But make sure that you keep on revising. Revision is the key source. Revision is the key source. And don't ever think that you are alone and you are doomed and nothing is happening. You are forgetting everything. To forget everything, if you forget, that is good sign. That is good sign, because that tells you that you have actually studied. In your real exam you will do very nice. Automatically things will start coming to you, but you have to ensure that you have to make sure that whatever you are supposed to do today, you're doing that. So many students get depressed that maybe peer pressure is there, society is so demanding that at this time you are appearing for NEET, somebody's NEET is third time, somebody's appearing fourth time, somebody appearing second time, first time. So people demand so many things, but please note that you don't have to listen to everyone. These are last 7 days in your life, and these 7 days are going to define what branch are you going to stay in for the next 40 years. You don't have to listen to anyone. It's your life. You are supposed to run your life. You are the master of your life. You are the captain of your ship. You have to decide. Nobody is going to tell you that you should be doing this. You have to decide, and it's your time now. You have to focus on your studies and build that confidence. Yes, you can do it, whatever the result will be. But at least if you are honest in doing your work, if you are progressing every day. You remember this? If you are progressing every day, if you are progressing every day, I believe that you are doing the right job, and nobody can snatch the seat or the dream branch of your choice from you. So you will get it, provided you are focusing on yourself. You are not comparing yourself with anyone. It's okay, somebody might have done PSM lot of times, but अगर आपने नहीं किया तो that's fine. आज कर लिया ना. At least you are better than yesterday. If you are better than yesterday and you are progressing forward, you will reach somewhere. So trust yourself, trust God, and remaining everything. Nobody knows future. Future is all, it gives you anxiety. So don't think about the future. Think about today. Are you doing what you're supposed to do today? And have you done it? Yes, you have done it. All the very best, and stay focused. Take care, and bye-bye. And make sure that once you clear your exam, you remember this Garib Banda also, and tag us in your Instagram stories and in your success stories. All the very best, beta. All the best. Okay, take care. And any doubts, still, if you have the doubts, you are most welcome to ask on the Telegram group. Take care, and bye-bye.